Good evening, students. I hope all of you are doing well. Hello, students. How are you? Good evening. There is a brief introduction about myself because you need to know with whom you are going to sit for next few days. So we are going to start integrated respiratory medicine. So students, whenever I start medicine, this is the first question majority of students ask me. Sir, medicine is a big ocean, lot of confusion, what is the solution? So before teaching them medicine, I have to answer this question. Now let me simplify medicine for you. For example, I am standing in this room and I am speaking to you. It means there is something normally happening in my body which is making me to speak. Any process that normally happens in your body is called as physiology. So anything right happening in your body is physiology. So whenever I say my normal respiratory rate is somewhere 12 to 16 per minute, see, don't think why it is normal, because it is God's given gift to your body. In simple words, anything normally happening in your body, it is physiology. Now anything abnormally happening in your body, it is called as pathology. In simple words, anything right happening in your body, it is called as physiology. Anything wrong happening in your body, it is called as pathology. Now for example, there is a foreign body in patient's throat. So how will this patient fight against that foreign body? So what will his body do? If there is a foreign body in the patient's throat, yes, come on, tell me. So your body will try to enhance the respiratory effort. It will increase the cough reflex. So this patient with foreign body in throat will have respiratory symptoms such as cough, and because of increased respiratory effort, he will have breathing difficulty called as shortness of breath or dyspnea. In simple words, whenever there is abnormality happening in your body will try to fight against that abnormality. The manner it fights will manifest as clinical features. In simple words, anything right happening in your body is physiology. Anything wrong happening is called as pathology. How your body fights against that will be the clinical features. This is the stage when the patient reaches my clinic for my assistance. Now I am going to do clinical examination, and with help of tests called as investigations, I'll come to a conclusion. Excuse me. So what is that conclusion called as? Diagnosis. Gnosis means identification. Dia means correctly. That's why in CNS you are having features called as agnosia. Agnosia means inability to identify. Gnosia means ability to identify. Dia means correctly identify. So to correctly identify what is happening in the body, I need some tests called as investigations. Now if I feel that this disease is due to some biochemical abnormality, what is the subject I should be knowing about? Biochemistry. If I feel it is due to some microorganism, what is the subject I should be knowing about? Microbiology. If my eyes cannot see what is happening inside the body, I need an advanced imaging system. What is the subject dealing with all this imaging system? Radiology. So putting together your clinical examination, biochemistry, microbiology, radiology, you come to a conclusion. What is that conclusion called as? Diagnosis. Now tell me students, after diagnosis, what is the next step? What is the next step after diagnosis? If you don't treat, nowadays patients will beat. So next step is treatment. To escape that beating, you should know the art of treating. So what is the subject dealing with all these treatment related drugs? Pharmacology. Now if you take medicine as a big field, It is actually made up of all these subjects put together. In my discussion also, for very important diseases, first I'll tell you what is normally happening in the body, what abnormality has happened, how your body is fighting, how are you identifying, and finally treating it. So this respiratory medicine, I have made it into 30 cases. So for important diseases, I will create a clinical scenario and I'll help you to notice how these diseases actually manifest in real life case scenarios. Before going into integrated medicine, you should know the definition of medicine given by William Osler, who is considered as father of modern clinical medicine. He mentions that medicine is a science of uncertainty and an art of probability. So what does this mean? For example, there is a patient with shortness of breath. For this single symptom, there can be multiple causes. So for this single symptom, if you open your textbook for shortness of breath, there can be respiratory causes, there can be CVS causes, there can be GIT causes, there can be renal causes. But your expertise does not lie in knowing all those causes. Your expertise lies in that given clinical scenario. In that given clinical scenario, what is the most probable cause? What is the most probable cause you should be able to know. So medicine means not knowing all the 100 causes of a given disease. So if you know all the 100 causes of that given symptom, it is not clinical medicine, it is theoretical medicine. So what actually matters is clinical medicine. So clinical medicine is in that given clinical scenario. In that given clinical scenario, what can be the most probable cause? So that is what is meant by medicine is a science of uncertainty. A single symptom can have so many uncertain phenomena happening in the body. But your expertise lies in that given clinical scenario, what is the most probable cause. Medicine is a science of uncertainty and an art of probability, as given by William Osler. This 1 year or so, this will be your condition, lot of stress, worries regarding your career. This is a slightly westernized version. Now putting this into Indian style or Desi style, this will actually be the condition of a medical student. He will be having always some exams to face. He will be worried about his studies. His parents will be asking him, when will you settle down? And most important, relationships. There will be so many breakups and makeups. Because MBBS is such a long career, nobody wants to stay with you permanently. And most irritating part will be your neighbors. So way back in 2005, when I was giving my pre-PG exam, 2011 actually, in 2011, when I was giving my pre-PG exam, my neighbor used to come and ask my mother the same persistent question. Arey, your boy joined in 2005. Now it is 2011. Is he still studying or doing some sort of smuggling? So there is something common between us and smugglers. What is that? Both of us work more during the nights, whatever it is. So you have to face all these insults, then only you will get those great results. Now coming to NEET 2021 and INI set trends, this was the recent trends. More of case scenario based bulky questions. Previously, if there were 200 questions, so majority were direct questions. About 140 to 150 were direct questions. Single liner, like most common cause, what is investigation of choice, what is drug of choice. Right now we are having about 50 to 60% questions or case scenario based bulky questions. So case scenario based bulky questions. Then when they give lot of information, you should focus on what is important. So like in this image, see, important is this, not this. If at all they give you a big question, there will be lot of distractions. If you are attracted by distraction, your life becomes a distraction, like in this image. See, they will be giving you case scenario based bulky questions. They want you to get confused by all those distractions. So you should know on what you should focus. So focus on what is important. Understanding and applying the concept is key. Previously, it was just like knowing the concept. Now you should understand it, and you should also know how to apply it in the given clinical scenario. And time management is very, very important. Most of the students have told me that this year's paper, it was not very difficult, but we were unable to read 200 questions in the given amount of time. For that, you should do lot of practice, students. So we have DAMS question bank, we have DAMS clinical scenario based questions, we have subject wise test, grand test. If you only practice, you will know how to manage the time ultimately. Before I start my class, this is what I want every student to know. Never let down yourself thinking that I'm an average or an ordinary student and I cannot do extraordinary things. This actually happens whenever we are starting a very big subject such as medicine or surgery. So most of us feel that during our undergraduate career or during all these days we did not study anything. But the truth is the difference between ordinary and extraordinary is only that little bit of extra. The difference between ordinary and extraordinary is only that little bit of extra. So that little bit of extra effort, we will put it together in this next few days to achieve those exceptional outcomes. We shall walk confident, students, during the class rather running confused. Like I told you, for very important disease, I'll first tell you what is normally happening, what abnormality has happened, how your body is fighting, and how are you going to recognize finally. And for important diseases, I have made a specific clinical scenarios. All these clinical scenarios will be updated as PDFs. No need to worry. And any doubts, kindly note it down. We will discuss during the break. And because if there are many doubts, it will break the flow of the class. So just note it down. I will give you sufficient time. We can discuss during the break. So write down. This is the first topic. Basic role of surfactant. Even though it will be discussed later in pediatrics regarding the development of surfactant in pediatrics and OBG, only if you understand regarding surfactant, you can understand few diseases in adults. So write down, surfactant is predominantly made up of diampalmitoyl phosphatidylcholine. All these are previously asked questions. It is produced by type 2 pneumocytes, removed by pulmonary alveolar macrophages. Surfactant is predominantly made up of dipalmitoyl phosphatidylcholine. It is produced by type 2 pneumocytes. It is produced by type 2 pneumocytes. It is removed by pulmonary alveolar macrophages. So production by type 2 pneumocytes, removal by pulmonary alveolar macrophages. And coming to the functions, surfactant is known to decrease surface tension. It is known to decrease surface tension and it is necessary to maintain alveolar stability. So just write down, I will discuss each and every word in detail in a short while. Decreases surface tension, it maintains alveolar stability, and a property of lung called as compliance. Compliance is nothing but stretchability. Compliance is nothing but stretchability. Surfactant decreases surface tension, maintains alveolar stability, and property of lung called as compliance. and a property of lung called as compliance. Now this surfactant is known to be production starts at 20 weeks. It is highest at 35 weeks. Any baby born less than 35 weeks can develop RDS. What is meant by RDS, students? RDS means, yes, RDS means respiratory distress syndrome. RDS means respiratory distress syndrome. Because it happens very early after birth. This was called as neonatal respiratory distress syndrome. And pathologically, in this disease, there were formation of hyaline membranes. So this disease was having hyaline membranes formed. So it was also called as a hyaline membrane disease. Neonatal respiratory distress syndrome. It is also called as hyaline membrane disease. Now first of all, let us see what is normally happening. Now consider, in one hand there is a balloon. In the other hand, there are set of alveoli. Simple common sense, students. In a balloon, whenever you blow in air, it will completely expand. When you release its neck, it will completely close. But your alveoli, during inspiration, they will open. During expiration, they will close but not completely. Now even at end expiration, your alveoli are kept partially open. Now what is the reason for this alveoli to be partially open? Because your alveoli is containing a substance called as surfactant. So this surfactant keeps your alveoli open even at end expiration. Now whenever surfactant is less, not formed properly, just like a balloon, your alveoli will also close at end expiration. Now tell me, students, when the alveoli are closed like this, alveolar collapse, this is called as alveolar collapse. Alveolar collapse is also called as alveolar atelectasis. During the next inspiration, to open this collapsed alveoli, should the baby apply more inspiratory effort or less inspiratory effort to open this collapsed alveoli? Now baby has to apply more respiratory effort. If somebody is putting more effort into respiration, will they be relaxed or will they be in distress? They will be in distress, because respiratory distress is happening very early after birth. This was called as neonatal respiratory distress syndrome. Whatever we have discussed up to now, let us put it into a flow chart. So write down pathophysiology. Normally at expiration, your alveoli are partially open like this. Now what is the reason for alveoli to be partially open? Because within the alveoli there is a substance called as surfactant. So write down, whenever there is surfactant deficiency, whenever there is surfactant deficiency, just like a balloon, your alveoli will completely close. Alveoli collapsed. Alveolar collapse is also called as atelectasis. Now, to open collapsed alveoli, to open collapsed alveoli. So very good, students. Everybody has answered it as more respiratory effort. Your body has to increase WOB. WOB means work of breathing. When somebody is putting more work into breathing, they will be in distress. So this phenomena is respiratory distress, as it is happening very early after birth. It was called as neonatal respiratory distress syndrome. Now a simple question. If a patient is reaching to the emergency department with chest pain, what is the next investigation that you usually advise students? A simple ECG. In the same way, when somebody is coming to you with respiratory distress, what will be the next investigation that you advise? It is generally a chest X-ray. Now, how to approach to a disease on chest X-ray based on pathophysiology? Now, you must be knowing, students, let it be any pathology or physiology. In chest X-ray, it has to manifest in only two colors. So, one is black, one is white. Most of you think radiologists have a colorful life, but in majority of situations they will see only two colors: X-ray black, white, USG ultrasound black, white, CT scan black, white, MRI black, white. So they appear colorful, but during their duty they only see two colors. One is black and other is white. Now tell me, students, what appears normally black on chest X-ray? So what appears normally black on chest X-ray? Anything containing air. Now what appears white on chest X-ray? Instead of calling it as your heart, your diaphragm, your ribs, in simple language, anything containing air will appear black. Anything containing less air or no air should appear white. So why is my heart white? It is not containing air. It is filled with blood. Why are my ribs white? Not containing air, made up of bone. Why is my diaphragm white? Not containing air, made up of muscle. In simple language, anything containing air will appear black. Anything containing less air or no air should appear white. Now, how to approach to a disease on chest X-ray based on pathophysiology? There are three steps. The first step, will the given disease cause a blackish abnormality or whitish abnormality? First step. Second step, what will be the extent of abnormality? Will it be a localized abnormality or will it be a bilateral diffuse abnormality? And third, and what will be the specific pattern of that abnormality? So three important steps. What will be the color of abnormality? What will be the extent of abnormality? And what will be the specific pattern of abnormality? Now let us apply this to radiological findings of neonatal respiratory distress syndrome. Now you only tell me, students, what will be the color of abnormality in this X-ray? So these alveoli are now not filled with air. So these alveoli are getting closed. So when they are filled with air, they appear black. So what will be the color of abnormality? Alveoli are not containing air. So it will be a whitish abnormality. Second step, what will be the extent of abnormality? Will it be a localized abnormality or will it be a bilateral diffuse abnormality? It will be bilateral diffuse, because whenever surfactant deficiency happens, it happens throughout the lungs bilaterally. And third, what will be the specific pattern of abnormality? Initially, these alveoli are tiny structures. So whenever they close, you can see bilateral whitish dots. So this bilateral whitish dots is called as granular pattern. As disease progresses, this white will become still more white, ground glass opacity, still more white, consolidation, completely white, whiteout lung. So the granular pattern, ground glass opacity, consolidation and whiteout lung are nothing but increased intensity of or increased density with respect to severity of disease. So write down the important findings. Very good. Akshay, Palak, Shruti, Amulya, Komal, everybody have answered it right. Akshita. So there will be either bilateral granular pattern bilateral granular pattern, bilateral ground glass opacities. So depending on the disease severity, you can see these densities. Actually these densities will be overlapping, but to make it simplified, I have discussed it separately. Bilateral consolidation, bilateral whiteout lungs, bilateral whiteout lungs, bilateral whiteout lungs. So these will be the various radiological features. Now coming to the treatment. Initially we give oxygen and CPAP. What is this CPAP? CPAP means continuous positive airway pressure. See, don't worry about all these densities. See, when we discuss various respiratory diseases, I will show you each and every abnormality in detail. Now just note it down. When we discuss various respiratory diseases, each and every abnormality I will show you in detail. Now initially it is oxygen and CPAP. If not improving, this baby requires a tube into the trachea, endotracheal intubation. And what is the problem here? There is surfactant deficiency. So one should give surfactant delivery. How it is actually done, it will be discussed in detail in your pediatrics. Regarding CPAP, we will know about it when we are learning obstructive sleep apnea. Don't worry. Now, even though this disease is exclusively happening in pediatric population, I am a person who is dealing with adults. So I am an adult respiratory medicine specialist. So why did I discuss here in detail? The reason is simple. In adults also there is a disease with similar presentation. What is that disease? ARDS. What is meant by ARDS? Acute respiratory distress syndrome. Only if you understand regarding surfactant function, you can understand ARDS better. See, this neonatal respiratory distress syndrome is no way concerned with an adult respiratory specialist like me. I generally deal with patients age more than 14. But why did I discuss here? Because you should be knowing about surfactant. Only if you understand regarding surfactant, you can understand a similar disease happening in adults. What is that similar disease happening in adults? It is ARDS. See, only if you understand the role of surfactant, you can understand ARDS better. What is meant by ARDS? Acute respiratory distress syndrome. Acute respiratory distress syndrome. Now let us see a clinical case. Now we have learned the theory. Let us see how a patient will present to you. So all these cases, it will be uploaded in the app, in the file section. Don't worry, just try to answer. There is a preterm baby. This was the question. There is a preterm baby with tachypnea within 4 hours of birth. So within 4 hours of birth, preterm baby developed tachypnea. Chest X-ray is shown. What is the diagnosis? Now this is the chest X-ray given in this case. This is the chest X-ray. For your convenience, I'll also bring a normal X-ray. So this is the normal X-ray of that age. Now what you can see in a normal X-ray, bilaterally the lung fields are appearing black. Whereas here, can you see the blackish lung fields? Tell me students, when compared to normal X-ray, so what is the color here? It is bilateral white. And if you keenly see, there are whitish dots here. So if you keenly see, there are bilateral whitish dots. So this is a granular pattern. And in the question they have given preterm baby and tachypnea within 4 hours of birth. preterm baby and tachypnea within 4 hours of birth. So what should be your diagnosis? So the diagnosis is neonatal respiratory distress syndrome. So neonatal respiratory distress syndrome, or also called as hyaline membrane disease. Now they can modify the question like this. So if they ask you, what is the reason for this presentation? See, diagnosis is neonatal respiratory distress syndrome. If they ask you what is the reason for this presentation, your answer should be surfactant deficiency. Or in few exams they can ask you like this: if at all biopsy is taken from this baby's lung, if at all biopsy is taken from this baby's lung, what will be the finding? If biopsy is taken from this baby's lung, what do you see under microscope? You see hyaline membranes. Either they can ask you directly what is diagnosis. They can ask you what is the defect. Defect is surfactant deficiency. Or they can ask you what can be the pathological finding. What can be the pathological finding? Your answer should be hyaline membrane disease. This is how they are framing the question. From a given concept, they can either ask you the diagnosis, they can ask you the defect, they can ask you what is the pathological change that can happen. Now from now onwards, so whatever disease that I discuss, it is strictly for adults only. Again, don't keep on asking, sir, what happens in children? See, when I say pneumonia, few students will ask me, sir, what happens in children? See, for children, you should follow pediatrics. So whatever disease that I discuss from now onwards, it is relevant to only adults. So we are going to discuss adult respiratory medicine only. So respiratory medicine related to children, the guidelines you have to follow pediatrics. So from now onwards, the entry is strictly for adults only students. If you feel yourself you are not an adult, I think this content will not be suitable for you. Up to now, we have discussed surfactant deficiency. Now, is there any disease happening in adults due to surfactant excess? See, anything excess is also not good. Excess boyfriends and girlfriends are also not good for your health. So such surfactant excess disease in adults happening is called as pulmonary alveolar proteinosis. So write down pulmonary alveolar proteinosis. The defect here is surfactant clearance. Anything excess is never good. Surfactant clearance impairment. Having one girlfriend is good. Having too many girlfriends is like walking in on fire. So defect, surfactant clearance impairment. Now coming to the etiology. How is surfactant produced, students? It is type 2 pneumocytes. How is it removed? Alveolar macrophages. Here the problem is in surfactant clearance. So where there is defect in the macrophages, probably. So write down etiology. It can be classified into two forms. We have a primary form called as most common form. So primary form, this is called as the most common form. And we have a secondary form. So primary form, it is due to autoantibodies against granulocyte macrophage colony stimulating factor, also written as GM-CSF. So this GM-CSF is required for proper functioning of alveolar macrophages. If that GM-CSF is not there in your body, is not functioning properly, alveolar macrophages will not be formed properly. So this GM-CSF is ultimately required for proper formation and proper functioning of alveolar macrophages. If there are antibodies, there will be no proper formation of macrophages, surfactant will not be cleared properly. Secondary form, it is due to silicosis, acute silicosis. Now, how is silica related to alveolar macrophages? Silica particles. So the relationship is similar to the relationship between India and Pakistan. Toxic to alveolar macrophages. Silica toxic to alveolar macrophages. So whenever somebody inhales silica, it can go and damage the alveolar macrophages. It will go and damage the alveolar macrophages. And when the alveolar macrophages are not functioning properly, surfactant will not be cleared properly. With this logic, when a patient is exposed to silica for long duration, it is called as chronic silicosis. What is the infection that can happen in his lung? In acute silicosis, huge amount of silica in short duration, it can result in pulmonary alveolar proteinosis. In chronic silicosis, what is the infection that can happen? Against which infection alveolar macrophages are first line of defense? Tuberculosis. Now once the alveolar macrophages are getting damaged, the defense mechanism to fight against TB decreases in your body. So the TB bacilli will come, proliferate easily, resulting in an active disease. That's why this entity is also called as silicotuberculosis. In acute silicosis, patient can develop pulmonary alveolar proteinosis. In chronic silicosis, there will be silicotuberculosis. Now coming to the pathophysiology. So this is the alveoli. Normally your alveoli will be lined with minute amounts of surfactant. Now there is excess surfactant getting filled. Now majority of the alveoli is filled with excess surfactant. Now this excess surfactant will not allow oxygen to go inside. So oxygen cannot go properly inside the body. There will be decreased transfer of oxygen. Whenever oxygen is not going into the blood, within the blood, oxygen decreases, resulting in hypoxemia. So point to be remembered, whenever there is less oxygen in your body will try to fight against this condition by taking more breath. See, hypoxemia can stimulate. So hypoxemia can stimulate the peripheral chemoreceptors, resulting in hyperventilation and respiratory difficulty. So this hypoxemia can result in respiratory difficulty. And point to remember, this surfactant is a whitish colored substance. So Chanchal, so you need to know some basic thing. So in your body, alveolar macrophages serve as a defense mechanism. So just like protection. So whenever TB bacilli come into your body, alveolar macrophages eat them, and finally they make sure it is not progressing into an active disease. Now in silicosis, what is happening? Silica particles are toxic to alveolar macrophages. So that defense mechanism is getting disturbed. Now suppose in front of your house there are 10 security guards not allowing thieves into your house. Now those 10 security guards are removed. Now thieves will come into your house and they create problem. In the same way, now once alveolar macrophages are damaged due to silica particles, now thieves called as tubercle bacilli can proceed into the tissues, into the lung tissues, and they can cause damage. So it can progress into an active disease. So this alveolar macrophages, you must be knowing, they are immune cells. Immunity means your body's defense mechanism. They are a part of defense mechanism, Chanchal. Now coming to the diagnosis. So for diagnosis, there are three important features. So first, when I put my bronchoscope into the lung and if I take sample out, what is that phenomena called as bronchoalveolar lavage? It is called as bronchoalveolar lavage. Now tell me, students, your lung is filled with whitish colored substance called as surfactant. Now if I put my bronchoscope and take the secretions out, what will be the color of those secretions? It will be white, and that white is described in textbook as milky white. Bronchoalveolar lavage will be milky white, and bronchoalveolar lavage, because of its contents, if you subject it to a special stain, it will be PAS positive. PAS means periodic acid skiff stain. So ball will be milky white. See, the color of surfactant is white. Now lung is filled with excess whitish substance. Now if you put a bronchoscope and if you suck out the secretions, it will be white. Then within the CT chest, within the CT chest, there is a classical pattern called as crazy paving pattern. So don't worry, what is this crazy paving pattern? In the next slide, I will discuss in detail. Bronchoalveolar lavage is milky white. It is PAS positive, and CT chest will show crazy paving pattern. Now coming to the treatment. So treatment will be, now lung is filled with excess surfactant, creating a lot of problem. Treatment will be putting a bronchoscope and sucking out the excess surfactant. Treatment will be whole lung lavage. Now I am going to put bronchoscope into the lung and suck out excess surfactant. Now if it is secondary form, once if you decrease the exposure to silica, recurrences will not happen. Now if it is primary form, after few months, again there will be reaccumulation of surfactant. According to the present evidence, even in recurrent cases, the only effective treatment available as of now is whole lung lavage. So point to remember, in primary form, there can be recurrences. Even in recurrences also, as of now, effective treatment is whole lung lavage. This is regarding surfactant excess condition called as pulmonary alveolar proteinosis. Now I'll show you some images related to pulmonary alveolar proteinosis. Identify them and tell me what is the answer. Now, what is this? This is the milky white bronchoalveolar lavage. So this is the milky white bronchoalveolar lavage. Before going into the classical CT chest finding, try to identify this image, students. Whenever you go to a park, you can see the pavement where people generally walk. So on the pavement, one can notice polygonal shaped stones arranged in an irregular manner. So this is a pavement. It was called as paving pattern because stones are arranged in an irregular manner. Anything irregular is called as crazy. So it was called as crazy paving pattern. So if somebody says that you are very crazy, don't think it is a compliment. It means you are very irregular. So you are not regular, you are different from, you are very irregular. It means you are something atypical. So crazy paving pattern. So this is pavement, and you can notice the stones are arranged in an irregular manner. Anything irregular, it is called as crazy. So it was called as crazy paving pattern. Now the person who has first identified CT chest finding in a patient with pulmonary alveolar proteinosis was very much obsessed with parks. He felt that lung architecture was also looking like polygonal shaped structures arranged in an irregular manner. Just tell me, students, can you find any similarity between these two images? Polygonal shaped structures arranged in an irregular manner. Polygonal shaped structures arranged in an irregular manner. Because these two images were looking similar, it was called as crazy paving pattern. It was called as crazy paving pattern. Now simple question, students. Why are the lung fields appearing bilaterally white here? Why are the lung fields appearing bilaterally white here? Normally my alveoli should be filled with air. Now instead of air, it is filled with excess surfactant. Any area where there is less air or no air, it should appear white. So this is a bilateral whitish density, and the specific pattern is crazy paving pattern. Let us see a real life case scenario, how a patient with this condition will present to you. They can give you in history a 39-year-old male stone crusher. So this was the stone crusher we knew previously. Whenever I mention stone crusher, what is the occupational hazard he is having? Exposure to silica. He can develop silicosis. He presented with progressive dyspnea on exertion for 5 months. He had long-standing cough with whitish sputum, but no fever, chills, weight loss and night sweats and other symptoms. So why am I asking about fever, chills, weight loss, night sweats and other symptoms? So to rule out any possibility of tuberculosis. The patient underwent bronchoscopy. There is milky white bronchoalveolar lavage. It is also PAS positive. Whenever there is silicosis history, ball is milky and it is PAS positive. With this information, your direct diagnosis should be pulmonary alveolar proteinosis. It should be pulmonary alveolar proteinosis. See, on the chest X-ray, Bichol-Roy, it will be bilateral whitish density. So it will not have a specific pattern. For better visualization, you go for CT chest. So chest X-ray findings are non-specific Bichol-Roy. So they are non-specific. You can identify bilateral whitish densities. Only if you look into the CT scan, you can identify that crazy paving pattern. Now this is pulmonary alveolar proteinosis. Now why it is not tuberculosis? Why it is not tuberculosis? Because patient is not having classical features of TB. Classical features of TB. Now why can't it be community acquired pneumonia? See, community acquired pneumonia is an acute respiratory illness presenting with fever, cough, shortness of breath. See, it happens within days to weeks. Here the history is 5 months and there are also no infective signs such as fever. So this is also not community acquired pneumonia. And why not it is simple silicosis? Because here patient is presenting with a complication called as pulmonary alveolar proteinosis. Here silicosis is the risk factor responsible for the disease called as pulmonary alveolar proteinosis. So here the patient is not coming to the emergency department because of just having silicosis. It is due to silicosis resulting in a complication called as pulmonary alveolar proteinosis. It is just like an obese male. He is coming to the emergency department with chest pain and you have taken an ECG. It is showing ST segment elevation MI. So now what will be the diagnosis there? Will you just write it as obesity because patient is obese? Will you write it as obesity and send him home because obesity is responsible for dyslipidemia, myocardial infarction? So this is obesity. Will you write and send him home? No. You will keep it diagnosis as myocardial infarction and you will treat myocardial infarction. Risk factor is obesity. In the same way, in this condition, the reason for presentation is pulmonary alveolar proteinosis. Diagnosis is pulmonary alveolar proteinosis. Risk factor will be silicosis. This is regarding pulmonary alveolar proteinosis. Now let us try to understand Weibull's lung model. According to Weibull, your airway, if you consider it as a family, a very big family, starting from trachea up to alveoli, In this family, there will be 23 generations of airway. There will be 23 generations of airways. Now in the family, if you consider trachea, so if you consider trachea as a great-great-grandfather, alveoli is the great-great-grandson. I told you, Akshita Raina, here the patient is not coming to a emergency department due to silicosis. I think tomorrow when you are in emergency department, when there is a patient with obesity, with chest pain, and ECG is showing myocardial infarction in the emergency department, kindly tell me, Akshita, will you call the consultant and inform that there is MI, and will you prepare for treatment for MI, or because MI has happened because of obesity, will you send him home writing weight reduction, do some exercise? By the time he reaches home, he will not reach home, he will not be there. So very simple logic, Akshita Raina. In the same way, here the risk factor is silicosis, and the disease in the emergency department or emergency is pulmonary alveolar proteinosis. So as a doctor, you should identify what is the most emergency situation. You should keep it as working diagnosis and you should treat the condition there. So here in no way you are treating silicosis. Here you have to treat pulmonary alveolar proteinosis. Just like if a patient, obesity is also a disease. If it is, you will not treat obesity first here. You will treat myocardial infarction. So just common sense. There is a patient with obesity and myocardial infarction. What will be the diagnosis? Will you just write it obesity or myocardial infarction? You will write it as myocardial infarction. That's why if you are treating in a patient with MI obesity, then the diagnosis will be silicosis. If you treat MI, then here answer should be pulmonary alveolar proteinosis. Which is most emergency, that will be the diagnosis. So that will be the focus of your treatment as a doctor, Akshita Raina. Now coming to Weibull's lung model. So there is, if you consider your airway as family, the great-great-grandfather is trachea, the great-great-grandson is alveoli. So in this family, there are 23 generations. So we have trachea. So trachea gives rise to principal bronchus. Trachea gives rise to principal bronchus. So Aditi Shankar, what does 5 months? See, it is not it is not an infection. So no infection, no community acquired pneumonia will be there for 5 months. So Aditi Shankar, no community acquired pneumonia will be there for 5 months. See, I am just requesting you, all these simple doubts you can ask me during the break, because it will just break the flow of the class. So trachea, principal bronchus, and from the principal bronchus you will get lobar bronchus. On right side, how many lobes will be there? Generally 3 lobes. On left side, only 2 lobes. And from the lobar bronchus, you will get so many segmental bronchus. segmental bronchus. From the segmental bronchus, after so many divisions, there will be terminal bronchiole. There will be terminal bronchiole. And from the terminal bronchiole, again there will be tiny divisions. So tiny divisions. So this tiny division is called as respiratory bronchiole. Respiratory bronchiole. From the respiratory bronchiole, you will have ultimate divisions called as alveolar duct and sac. So it is nothing but your alveoli. This is how a large central airway finally gives rise to a tiny structure called as alveoli. In this, what were the questions previously asked? So question number 1, in this division, up to what level is considered as dead space? Up to what level is considered as dead space? And what is considered as functional unit? Functional unit, also called as acinus. What is considered as functional unit, also called as acinus? What is called as functional unit, also called as acinus? Now tell me, students, what is meant by dead space? Can anybody tell me what is meant by dead space? It is area of ventilation but no gaseous exchange. In your airway up to terminal bronchiole, there will be ventilation, no gaseous exchange. This is called as dead space. Again, it will be discussed in your anesthesia, but you should know what is meant by dead space. Area of ventilation but no gaseous exchange. In your airway up to terminal bronchiole, it is called as dead space. Now your primary function of lung starts beyond the terminal bronchiole, which is nothing but gaseous exchange. So this primary function is happening beyond the terminal bronchiole, predominantly in the alveoli. This area where primary function called gaseous exchange is happening, it is called as functional unit or acinus. So this is distal to terminal bronchiole. Distal to terminal bronchiole is functional unit, also called as acinus. Now how is this clinically helpful for me? I come across a disease called as COPD emphysema. In emphysema, which part of the lung is destroyed? Now tell me, students, emphysema, what is the definition? It is destruction. It is destruction distal to terminal bronchiole. What is present distal to terminal bronchiole? What is it called as? Acinus. That's why whenever you are studying pathology, when you come across types of emphysema, what did you discuss? Centri-acinar, pan-acinar, distal acinar. Because gas exchange area called as acinus is getting destroyed here. These patients ultimately presents with impaired gaseous exchange. These patients ultimately present to me with impaired gaseous exchange. So the gas exchange will not be proper. Because gas exchange is not happening properly, always these patients will be having some respiratory discomfort. That is the reason why in emphysema there is impaired gaseous exchange, because gas exchange areas called as acinus are getting destroyed. Emphysema means destruction distal to terminal bronchiole. Now you know that the trachea is giving rise to right main bronchus and left main bronchus. Now tell me, students, on which side aspiration is more common and on which side bronchiectasis is more common? Come on, tell me, students. on which side aspiration will be more common and on which side bronchiectasis will be more common. Very important. Right side aspiration tends to be more common, whereas on the left side bronchiectasis is more common. So write down, next important topic is aspiration versus bronchiectasis. BXIS is short form of bronchiectasis. So wherever I write BXIS, I mean bronchiectasis. Now let us see the reason behind this. You all must be knowing there is a large central airway. Very good, Chanchal. Right side aspiration. Very good. Yes, Varun Kumar, Sai Shruti, Akshay, everybody have answered it right. Vikrant, right. Now there is a large central airway called as trachea. This trachea gives rise to a right main bronchus and a left main bronchus. Anatomically, when compared to left, my right main bronchus tends to be short. It tends to be stout. It tends to be bit straighter, shorter, stouter, straighter. Because of that, any fragment reaching the trachea, its tendency is to fall more on the right. So that's why there is increased chances of aspiration on the right. Your right main bronchus tends to be shorter, stouter, straighter when compared to left main bronchus. So that's why there is increased chances of aspiration. There is increased chances of aspiration on the right. Whereas left main bronchus, anatomically, it is narrow, angulated and decreased drainage of secretions. Now see here, if at all some secretions pull up, for example in right main bronchus, if the patient is having a very good cough reflex, these secretions can be expelled out. So it is easy to come into the right and it can also be expelled well from the right. But if unfortunately some secretions come and pull up in the left, so it is going to stay there for long. So there will be increased stasis of secretions. Whenever secretions are staying there, it can attract infections. Because of infections, there will be inflammation. This infection and inflammation will cause destruction of muscle and elastic tissue. So around your airway, there is a strong muscle. So that is responsible for firmness of the airway. This infection and inflammation can destroy that predominant muscle, and because of that your airway can dilate. Destruction of muscle and elastic tissue can result in dilatation of airway. This dilatation of airway is called as bronchiectasis. So in simple words, on right side aspiration will be more common. On left side bronchiectasis tends to be more common. Another simple question, students. On the left side you have left upper lobe and left lower lobe. Left upper lobe and left lower lobe. So by common sense, which lobe will be more involved in bronchiectasis? Now see here. If at all secretions pull up in the upper lobe, if the patient is having some effective cough reflex, he can still cough it out. But if the secretions are pulling on the lower lobe, it is very difficult to expectorate, resulting in bronchiectasis. That's why lower lobes more involved in bronchiectasis. Lower lobes more involved in bronchiectasis. So this is a concept of aspiration versus bronchiectasis. Now you know that bronchiectasis commonly happens in the left side, that too on the lower lobe. Now this aspiration generally happens on the right side. Now the next question will be depending upon patient's position. If the patient is sitting, or if the patient is standing, or if the patient is in supine position, if the patient is in supine position, what will be the bronchopulmonary segment preferably involved? See, according to patient's position, what will be the bronchopulmonary segment involved in aspiration? So write down, students, bronchopulmonary segments and aspiration pneumonia. Next topic, bronchopulmonary segments and aspiration pneumonia. Let us first see the previous questions asked. Most common segment involved in aspiration pneumonia. Most common segment involved in aspiration pneumonia: overall, supine position, sitting or standing position. These were the questions previously asked. Most common segment involved in aspiration pneumonia. Most common segment involved in aspiration pneumonia. Overall, supine position, sitting or standing position. Now the concept here is the most common segment involved in aspiration pneumonia, overall and supine position will be the same. Let us see the logic behind this. Now tell me, students, in whom aspiration pneumonia frequently happens? In patients with poor neuromuscular reflexes, in whom the neuromuscular reflexes are not proper. Now tell me, students, if the nerves and muscles are not functioning properly, will they be actively moving or will they be bedridden? They will be bedridden. And whenever somebody is bedridden, what is the common position that they prefer? It is supine position. Now the answer for overall and supine position is similar, because aspiration pneumonia frequently occurs in bedridden patients, and bedridden patients are generally in supine position. So the answer why overall and supine position, why the segment for overall, the reason why for overall and supine position is the same. The reason is aspiration pneumonia. This aspiration pneumonia frequently occurs in bedridden patients. Frequently occurs in bedridden patients. And generally bedridden patients are in supine position. Now to understand what is the segment involved, you should know the anatomy of right lower lobe. So if you just know the anatomy of right lower lobe, it is sufficient. Now how many bronchopulmonary segments are there in right lower lobe, students? There are 5 bronchopulmonary segments. So very simple to remember. So right lower lobe can be divided into upper portion, lower portion. In the upper portion, this is medial segment. This everything extending up to the scapula is superior segment. And in the lower portion, anterior segment, lateral segment and posterior segment. So if they ask you what is the lowermost segment, it is the posterior segment of right lower lobe. So very simple, medial segment extending up to the scapula is superior segment. In the lower portion, anterior segment, lateral segment, and this is posterior segment. Now let me draw it for you to understand. So I am taking the right lower lobe separately. And on the side on view, these are the segments. This is the right lower lobe bronchus. This will be the segmental arrangement if you see from the side. So what is this segment? So the topmost segment, it is the superior segment. This is the medial segment. This is the medial segment. This is anterior segment. Anterior segment. And this will be the lateral segment. And the lowermost segment, it is the posterior segment. So I'm just drawing the diaphragm also. So this is the posterior segment. This will be the posterior segment. So this will be the arrangement of bronchopulmonary segments. So when the patient, you see the patient sidewards in sitting or standing position. Now simple common sense, students. Now if at all a particle is getting aspirated into the lung. So let this be the aspirated particle. You must be knowing aspiration is nothing but something falling into the lung. See, anything falls down has to follow one law of physics called as gravity. Anything that falls down has to follow one law of physics called gravity. So whichever segment is closer to the earth, whichever segment is closer to the ground will be more influenced by gravity. Now if a patient is sitting or standing, now see here, if a patient is sitting or standing, this will be the condition of his bronchopulmonary segments. Now if he aspirates, so that particle will reach the segment which is more dependent in that position, segment which is more closer to the ground. What is that segment? Posterior segment. So the answer for sitting or standing position, the answer for sitting or standing position by gravity. See, everything in this universe works by gravity. Newton said the same, Einstein says the same, Stephen Hawking also said the same. Everything works on the principle called as gravity. So when the aspirated fragment is reaching the right lung, so by gravity it will reach to the right lower lobe posterior segment. In sitting or standing position, it is right lower lobe. It is right lower lobe posterior segment. It is right lower lobe posterior segment. Now suppose patient is in supine position. So whenever he is in supine position, whenever he is lying like this, this will be the position of his bronchopulmonary segments. So what is this segment which is on the top? It is superior segment. So I have just highlighted the superior segment for you to understand. Now tell me, students, when you lie down also, which part will be closer to the ground? Which part will be closer to the ground? So this scapular area. So this scapular area will be closer to the ground. Now tell me, whenever somebody aspirates in supine position, majority will reach to this segment. So which is a segment extending at the scapular area? It is superior segment. And some part can also reach to this part. So this is right upper lobe. So this is right upper lobe. And what is this part? So you can see the spinous process. So it has to be the posterior part. So the best answer is right lower lobe superior segment. Right lower lobe superior segment. If it is not given in the option, the next best answer is right upper lobe posterior segment. It is simple common sense. Even you lie down, if you don't understand this concept, when you lie down, the scapular part will be touching the ground. So at the scapular part, you will have right lower lobe superior segment. Along with that, some part of right upper lobe posterior segment. So in supine position, very simple to remember, it is supine position. So the answer should be superior segment. So for you to understand, once again, students, if you are standing like this, most dependent part will be this. What is this? Right lower lobe. So just so most dependent part will be this. So this is right lower lobe posterior segment. If you lie down, now the dependent part will be this scapular portion. At this part you have right lower lobe superior segment and some part of right upper lobe posterior segment. So very simple concept. It is just like the position of bronchopulmonary segment according to patient's position and influence of gravity. So most common segment involved in aspiration pneumonia, overall supine. It is right lower lobe superior segment, followed by right upper lobe posterior segment. In sitting or standing position, it is right lower lobe posterior segment. Sometimes these aspirated substances can be foreign bodies, and these foreign bodies, based on their appearance on chest X-ray, they can be classified into two types. If you can see the clear-cut opacity on the chest X-ray, in the clear-cut opacity on the chest X-ray, it is called as radio opaque foreign body. If you are unable to see the opacity on chest X-ray, it is called as radiolucent foreign body. So write down, foreign bodies are of two types. Sometimes these aspirated substances can be foreign bodies. Radio opaque foreign bodies, radiolucent foreign bodies. Radio opaque foreign bodies, radiolucent foreign bodies. Radio opaque foreign bodies. Tell me students, which foreign bodies can create a clear-cut opacity on chest X-ray? Yes. Which foreign bodies? See, Bishal Roy, where is medial and anterior segment? See, Bishal Roy, this is medial segment, this is anterior segment. Still don't understand. Even after writing medial and anterior segment, why are you asking again where is medial and anterior segment? See, in a normal individual, see, kindly take your hand and paracardiac, you place it here. Okay, don't ask me where is heart. Okay, or parasternal. Okay, parasternal near the heart border. So this is medial segment. You'll have medial segment here, and below that anterior, lateral, posterior. Okay, anterior, lateral, posterior. So I have shown you here Bishal Roy. Anterior segment will be roughly here, medial segment. See, your lung can be slightly rotated. So because of that, you can see medial segment more, and there will be anterior, lateral, posterior. So radio opaque, radiolucent. So radio opaque, metals. So anything made up of metal, it can be coins, it can be batteries, it can be pellets, and teeth. So teeth are also radio opaque. So teeth are also radio opaque. Teeth are also radio opaque. Then coming to radiolucent foreign bodies. Can you tell me example of radiolucent foreign bodies? Yes, radiolucent. See, metals are radio opaque. Radiolucent, we have wood, plastic, food particles. Wood, plastic, food particles. So metals, teeth are the frequent radio opaque foreign bodies. Plastic, wood, food, and wood. All these are radiolucent. Radiolucent foreign bodies. Radiolucent foreign bodies. See, Ruchir Desai, we are discussing about common things. Insects are not that common. So insects, depending upon their architecture and their skeleton, they can be radio opaque, and sometimes there can be radiolucent. So if you are having a habit of, if anybody is having habit of eating mosquitoes, eating any house flies, so there it will be radiolucent only, because rarely they go into the lung, and if they are going into the lung also, so it will not be appearing because they are not having any skeleton there. So radio opaque, radiolucent foreign bodies. Okay. Now I'll give you an example. So there was a 45-year-old female. She recently had a dental implant. So she recently had a dental implant. So recently she had a dental implant. Next day morning she came running to my hospital telling that her dental implant was missing. So immediately we have taken a chest X-ray. So when we have taken a chest X-ray, this was what I could identify. Can anybody tell me what is the problem here? Now can you see on the chest X-ray a well-defined opacity, similar to her dental implant? Yes. Similar to her dental implant? Yes. So what must have happened? She had a costly dental implant. During the night, the dental implant must have dislodged and she must have aspirated. So during the night, the dental implant must have become loose and it must have got aspirated in the lung. Whenever it is a radio-opaque foreign body, life is very easy because you know exactly where the foreign body is present. You can put a bronchoscope and you can remove it. So whereas whenever it is radiolucent, it is very difficult to identify. In such situation, you need exact clinical history. For the patient to know whether there is foreign body. Okay. So D. Manasa, non-veg bone, mutton, non-veg fish bone. See, it depends upon the piece. So if it is a big piece, it will be identified. If it is a small piece, it will be difficult to identify on a chest X-ray. Okay. So I'll just give you an example so that you will understand. So difference between radio-opaque and radiolucent. And for your kind information, generally D. Manasa, fish bones and mutton bones, they will be of big size. It will be difficult to pass the trachea and go into the lung. So here we are discussing foreign bodies in the lung. So fish bones in the throat, that will be discussed in your ENT and you will see lot of X-rays there. Don't worry. Now coming to a clinical example. So there was a 30-year-old recently married male. So his wife was out of town. He had a big alcohol party at home. So whenever they mention alcohol party at home, wife out of town, alcohol party at home, what you should suspect? Aspiration history. So whenever they mention alcohol, you should also suspect aspiration history. So this fellow had alcohol party with his friends and he aspirated. He was brought to the emergency department. So in the emergency department, they have taken a chest X-ray. Now what is the abnormality that you find on the chest X-ray? This is right lung, this is left lung. So left lung is completely expanded. Okay, there is no issue. Whereas right lung, you can see a homogeneous whitish density. Such homogeneous whitish density is called as collapse. So there is aspiration history and collapse on chest X-ray. Now what is meant by collapse? Collapse means airless lung filled. A part of lung is not containing air. So why this can happen? Now whenever the foreign body is large enough, it will occlude a bronchus. So whenever there is bronchial obstruction, so distal to that bronchus, will there be more air or less air? Less air. After some time, no air. So this airless lung field is called as collapse. So if there is aspiration history and collapse on chest X-ray, you should suspect. So Palak, it is not consolidation. So consolidation will have air bronchograms that I will show you later, don't worry. So as of now, this area is completely white. So it is densely white. So this dense airless lung field is called as collapse. So whenever there is collapse on chest X-ray with aspiration history, you should suspect foreign body. You should suspect foreign body. You should suspect foreign body. So whenever there is foreign body, what is the best investigation? So best investigation, your answer should be, whenever there is foreign body in airway, scope is the only hope. What is that scope? Bronchoscope. So best investigation is bronchoscopy. Best investigation is bronchoscopy. So why I consider bronchoscopy as best investigation? So why bronchoscopy is considered best investigation? Bronchoscopy, it will not only visualize the foreign body, it will also retrieve the foreign body. Now I also suspected a foreign body in this patient. And immediately have done a bronchoscopy. So this was what was found. So in the bronchoscopy, this is the video. Can you see a brownish substance in the lung? Yes. So it took me about 10 to 15 minutes. So this is the bronchoscopy procedure that I am doing. It took me about 10 to 15 minutes to remove this foreign body. So can anybody answer Chanchal's question? So how can it block? So what is this foreign body? Yes. What is this foreign body? So this was aspirated chicken liver piece. Patient was so much drunk. Instead of putting it into his stomach, he put it into his lung. So Chanchal, you must be knowing this. People who drink alcohol, they don't just drink alcohol. They eat some food. So they have items as snacks. Snacks are multiple varieties. So that will take around 1 or 2 hours to explain. That is a separate class. So during their eating those snacks, so snacks can be chips, snacks can be mutton, fish, anything like that. So during eating that, because of alcohol, swallowing reflex will decrease, cough reflex will decrease. It can get aspirated into the lung. So this was a aspirated chicken liver piece. Okay. Now, what is the moral of this story? Drink responsibly. Don't aspirate and waste alcohol. This fellow didn't know how to drink properly. He aspirated and created all this mess. But this is not what you should remember for your exam. So what you should remember for your exam is, whenever there is aspiration history and collapse on chest X-ray, your suspicion should be foreign body and best investigation should be bronchoscopy. So when I did bronchoscopy for this patient and later he woke up, and the first question that he asked me was not regarding his condition. Did my wife came to know about this situation? I told him yes, and he was in great shock. I don't want to tell you what happened next. So these are the things that can routinely happen whenever wife goes out of town. So drink responsibly. Now try to solve this question, students. Try to solve this question. A bedridden patient. There was a bedridden patient. So whenever they mention bedridden patient, whenever they have mentioned bedridden patient, yes. See, Bishal Rai, what is the first investigation? See, I don't know why you are unable to follow. There was a patient like this. After that, we have taken already chest X-ray, na? Already chest X-ray is there. So when I say I have taken a chest X-ray, so that is the first investigation, na? See, aspiration history, there is collapse on chest X-ray. When I have already written there is chest X-ray, again you are asking me, sir, is chest X-ray the first investigation? I told you I have already taken chest X-ray first. It means it is first investigation. Okay. So this, write down, there is a bedridden patient. Bedridden patient means he is in supine position. On liquid diet, develops aspiration pneumonia and resulting in a lung abscess. So which of the following is the bronchopulmonary segment most likely affected? Which will be the bronchopulmonary segment most likely affected? Tell me, students. In supine position, your answer should be right lower lobe, superior segment. If it is not given, next best answer is right upper lobe, posterior segment. So now choose the options. So is it left? It's not left. So it is posterior segment. Yes, it is not of lower lobe. So it is not posterior segment of lower lobe. So the best answer is right lower lobe, superior segment. It is not given. So you should go to next best answer. Posterior segment of right upper lobe. Posterior segment of right upper lobe. So which of the following is bronchopulmonary segment is most involved? It is posterior segment of right lower lobe or right upper lobe. So actually the answer, the best is superior segment, but it is not given in the option. So you should go for next best right upper lobe, posterior segment. Now what is this symptom in respiratory medicine called as, students? What is this? Blood in sputum. It is called as hemoptysis. Write down hemoptysis. See, your lung is having dual blood supply. Lung gets blood supply from two sources. One is a high pressure. One is high pressure systemic circulation. One is high pressure systemic circulation, that is bronchial artery. Bronchial artery, and other is low pressure pulmonary circulation, that is pulmonary artery. Say lung is getting two sources of blood, high pressure systemic circulation, bronchial artery. Low pressure pulmonary circulation, that is pulmonary artery. These were the questions previously asked. What is most common source of hemoptysis and what is most common source of massive hemoptysis? Massive hemoptysis. Yes, tell me, students, what is most common source of hemoptysis? What is most common source of massive hemoptysis? Now there is a high pressure circulation and a low pressure circulation, which has more tendency to rupture high pressure. Because it ruptures at high pressure, to control it, it might be difficult for the body and it might result in massive hemoptysis. So most common source of hemoptysis and massive hemoptysis because of high pressure circulation, your answer should be bronchial artery. Your answer should be bronchial artery. Then what is the definition of massive hemoptysis? Massive hemoptysis is defined as more than 100 to 150 ml of blood per episode or more than 400 to 600 ml of blood per day. So the standard definition is, if a patient is expectorating about 100 to 150 ml of blood in a single episode or 400 to 600 ml of blood throughout the day. See, the total amount was 400 to 600 ml. So it is called as massive hemoptysis. Next set of questions. What is most common cause of hemoptysis in India? What is most common cause of hemoptysis worldwide? Now tell me, students, in India, what is most common cause of hemoptysis? Say it loud and proud. It is our national disease, tuberculosis. Say it loud and proud. It is our national disease, tuberculosis. Then, what is most common cause of hemoptysis worldwide? In the old edition of Harrison, once they have mentioned it as chronic bronchitis, later malignancy. But now they have recognized it as tuberculosis. The simplest reason is, nowadays Indians are worldwide. It will be our national responsibility to share. We share everything on Facebook, WhatsApp, without verifying. In the same way, we are sharing our national disease worldwide. So let it be worldwide or India. Now it is tuberculosis. Just like national bird, national animal, it should be given the award national disease. So write down most common cause of massive hemoptysis, most common cause of death in massive hemoptysis, and most important in management of massive hemoptysis. Recent studies have shown that most common cause of massive hemoptysis is bronchiectasis. Then what is most common cause of death in massive hemoptysis? So why will a patient die actually because of massive hemoptysis? It is not due to blood loss and shock. Before that something can happen. That can kill the patient. Okay, what is that? Yes. See, there will be, whenever there is massive hemoptysis, excess blood within the lung. So that blood can reach the trachea. Whenever blood is out of blood vessel, it can form a clot. So that clot can cause asphyxiation and death. See, for blood loss to happen and create shock, it will take about 10 to 15 minutes. But if somebody tightly holds your neck, for how much time you can survive? Not more than few minutes. So that clot can cause asphyxiation and sudden death. Most common cause of death is asphyxiation with blood clot. Then what is most important in management of massive hemoptysis? No doubt, both airway and circulation are important. Out of these two, if they ask you what is most important, your answer should be airway maintenance. You should make sure his airway is free from blood clots. Patient's airway is free from blood clots. These are some one-liners that can be asked in hemoptysis. Most common source, massive hemoptysis, cause, death in massive hemoptysis, what is most important in management of massive hemoptysis. See, all were previously asked questions. Now if at all there is a patient with hemoptysis, what are all the possible etiologies? So write down etiology of hemoptysis. Etiology of hemoptysis. Very, very important. If you can adequately collect the clinical history, you can avoid so many unnecessary investigations, students. In etiology of hemoptysis, clinical history is very, very important. Majority belong to these groups only. So majority. If there are 100 cases of hemoptysis, 60 to 70% fall into this majority group. If you take simple history, you will know whether it is infective neoplastic. Along with that, minority can be due to cardiovascular causes, systemic causes, and traumatic causes. So this traumatic cause will be dealt by my general surgeon friend. So I am going to discuss the medical causes here in detail. So infections, it can be due to Mycobacterium tuberculosis, other bacterial infection. Any infection can cause viral infections, fungal infections. Along with that, infection of bronchi, such as bronchitis. So infection of central airways, bronchitis, and also infection and destruction of airways. More severe form, bronchiectasis. Infective manifestations such as bronchitis, bronchiectasis can result in hemoptysis. Now coming to neoplastic. It can be due to either primary tumors of lung or it can be due to metastasis. primary tumors or metastasis can cause hemoptysis. Cardiovascular causes will be dealt in your cardiology, cardiac failure, mitral stenosis, pulmonary embolism, pulmonary arteriovenous malformations, pulmonary arteriovenous malformations. Now in this disease, pulmonary arteriovenous malformation, there will be some abnormal connections between pulmonary artery and veins. Any abnormal connection generally will be weak and it will break, resulting in hemoptysis. Systemic causes such as coagulopathy, then alveolar hemorrhage syndromes, pulmonary renal syndrome such as Goodpasture syndrome. In Goodpasture syndrome, what can happen is there will be autoantibodies against your glomerular basement membrane and alveolar membrane. Patient can have hematuria and hemoptysis. The next important reason, connective tissue disorder related lung disease. CTD means connective tissue disorder. These connective tissue disorders, as a part of systemic involvement, can directly involve the lung, damage the lung, resulting in hemoptysis. And small vessel vasculitis. You must have come across in rheumatology small vessel vasculitis such as Wegener's granulomatosis, microscopic polyangiitis. Because of involvement of pulmonary vessels, there can be hemoptysis. But point to remember, these are not majority causes. So these are only seen in minority. Now whenever you take adequate clinical history, you can easily know whether he is belonging to majority cause or minority. So if you feel it is infective or neoplastic, so what will be the probable evaluation? So evaluation, you can start with a simple complete blood count. So complete blood count will give you the information about his hemoglobin. So because of the hemoptysis, did he lose blood? And next important thing, the neutrophil count can tell about infection. A simple chest x-ray will help, and sputum examination. So sputum, you are examining for bacteria, you can examine for fungus. Then CT chest will exactly tell you the anatomical abnormality, will tell you the morphology of the disease. And to see directly into the lung, you can go for a diagnostic bronchoscopy. We have fiber optic bronchoscopy, flexible bronchoscopy, written as FOB. So we have two types of bronchoscopies. So one is fiber optic, also called as flexible bronchoscopy, and other is rigid bronchoscopy. Generally for diagnostic purposes, we use flexible. For therapeutic, we use rigid. So why we use for therapeutic, I'll just tell you in a while. Just note it down. So for evaluation, simple complete blood count, chest x-ray, sputum examination, CT chest, fiber optic bronchoscopy. Now if you are suspecting this, minority conditions. If you suspect a heart disease, ECG, 2D echo will give you information. If you are suspecting any pulmonary embolism, D-dimer. If you are suspecting any pulmonary vascular abnormality, let it be embolism or AV malformation. To exactly see the pulmonary vasculature, a CT pulmonary angiography will be helpful. If you are suspecting in terms of coagulopathy, coagulation profile. If you are thinking about any Goodpasture syndrome, because there will also be, apart from renal biopsy, a simple urine examination. There will be hematuria there. And if you are thinking in terms of connective tissue disorder, small vessel vasculitis, all these are autoimmune diseases. And for all these diseases, there is antibody testing. So you can go for specific antibody testing for autoimmune diseases. For autoimmune diseases, we have antibodies which can be present in a specific autoimmune disease. This will be the general evaluation of a patient with hemoptysis. These are the routine causes that we come across. But keep in mind, students, in majority of the patients, it will be either infective or neoplastic. Infective or neoplastic. Now suppose there is a patient with hemoptysis coming to the emergency department. Now in emergency department, the situation will be completely different, because if at all patient is having massive hemoptysis, it is a medical emergency, because there can be sudden death in the patient. So this is evaluation of hemoptysis if he is coming to the outpatient department. Now there is a situation where there is a patient with hemoptysis reaching to the emergency department. So for emergency department, there is a separate algorithm. For emergency department, there will be separate algorithm. Now suppose you are a new intern posted in the emergency department. It was 10 o'clock in the night. You and your co-intern were discussing about Goa vacation plans. You have just started your internship. You started discussing about Goa vacation plans, which is never going to happen, especially in internship. Now there was a patient with hemoptysis. So what is the first thing you should do? You should stop discussing, go and see the patient. And you should inquire, is it massive hemoptysis? Is it massive hemoptysis? Or is it non-massive hemoptysis? Is it massive hemoptysis? Non-massive hemoptysis. If it is non-massive hemoptysis, you can relax for a while. But if it is massive hemoptysis, immediately you should be on your toes. You should stratify the patient. Is this patient stable or unstable? When do you call a patient is unstable? His sensorium is not good. His vitals are not good. His BP is low. His saturation is low. So for unstable patient, you should immediately stabilize the patient. And you should call me, the consultant pulmonologist, so that I will perform a rigid bronchoscopy to save the life of the patient. A rigid bronchoscopy. Now, you know that there is flexible and rigid. Now what is the advantage of rigid bronchoscopy, especially in massive unstable patient? So this rigid bronchoscope has a bigger suction channel. Now tell me, students, what will be the benefit of bigger suction channel? It can suck out the clots and save the life of the patient. So this rigid bronchoscopy deals with the bleed better. It deals with the bleed. It deals with the bleed better. It deals with the bleed better. Now if the patient is stable, you can send him to a CT chest, and depending on that, we can plan for a fiber optic bronchoscopy. Now if the patient is having non-massive hemoptysis, you can continue your discussion but write a chest X-ray, and depending on the chest X-ray, is patient's chest X-ray normal or abnormal? Is chest X-ray normal or abnormal? Your next evaluation depends on. Now if the patient's chest X-ray is normal, you have to divide the patient into two. Are you dealing with a low risk patient or high risk patient? Now what is meant by risk. Even though most common cause of hemoptysis is tuberculosis, whenever you are going across an algorithm, you should rule out most dangerous cause first. So dangerous cause, I say, is malignancy. So why malignancy? Because even if you miss tuberculosis today, and if you identify it after few days, the treatment will be the same. But if you miss malignancy now, and if you identify at a later date where there will be extensive metastasis, then nobody can treat. See, Chanchal, stabilizing the patient is ABC. This is basic. Airway, breathing, circulation. If saturation is less, give oxygen. If airway is not properly intubate him. His BP is less, give IV fluids. So you know everything. Again you ask, sir, is it the same? So stabilization anywhere for any patient will be the same. A, B, C. Maintain airway, breathing, circulation. Stabilization anywhere will be the same. A, B, C. So who are at high risk of developing lung cancer? Who are at high risk of developing lung cancer? Smokers and increased age. So previously the age risk factor for malignancy was 60 years. Now it has been reduced to 40 years thanks to air pollution. Tomorrow what will happen, nobody knows. So low risk, it is non-smokers and age or young patients. Non-smokers, young patients. Then coming to low risk. If at all patient is belonging to low risk, so just take some history. Was it a single episode? Or see, if you want to confirm any simple things, kindly ask during the break. It will not spoil the flow of the class. If it is a complicated thing, I will generally discuss then and there itself. So if it is a simple thing, if you want to confirm, just ask me during the break, it will be more helpful. Or else the discussion will continue for hours together. So it will just, what will happen is we will be stuck at a single topic. So we'll be not moving forward or backward. So that's why I want you, I'm telling you, if you're having any simple doubts, you ask me during the break. So single episode, or is it multiple recurrent episodes? So if it is single episode in the emergency department, you just reassure him, and especially in the young patient. In young patient, it can be due to some upper respiratory tract infection. You can reassure and you can keep an antibiotic and ask him to go to the morning OPD. Now if it is recurrent, so there is some issue in him, you can write a CT chest followed by fiber optic bronchoscopy. Now tell me students, if there is a high risk patient, even a single episode, you should not neglect. In this situation, you should go for CT chest followed by fiber optic bronchoscopy. Now if the patient's chest X-ray is abnormal according to new guidelines, so here also it is CT chest followed by fiber optic bronchoscopy. So this is the algorithm in emergency department. Now my question here is students, in majority of situations, we first do CT chest, then only fiber optic bronchoscopy. Now what is the advantage of CT chest? What is the advantage of CT chest? Yes, what is the advantage? CT chest will give you the precise anatomical location of the disease, where the disease is present, right side, left side, precise segment. Then what is the benefit of doing bronchoscopy later? Now with help of a bronchoscope, you can directly go into the diseased part. You can visualize the diseased part. If there are some secretions, you can take bronchoalveolar lavage. If there is an abnormal tissue, you can take bronchoscopic biopsy. by sending the secretions, by sending the biopsy to the laboratory, you will get a diagnosis. Once you treat the diagnosis, hemoptysis can also resolve. CT chest will give you the precise anatomical location. Fiber optic bronchoscopy, direct visualization and collection of sample. Now why in unstable patient? So why in unstable patient I am not sending him to CT chest, I am directly proceeding to bronchoscopy? Because if I send him to CT chest, he will never return back to me. He is unstable. He will collapse on this CT table itself. So in unstable patient, this rigid bronchoscopy is not just diagnostic, it is also therapeutic. In unstable patients, massive hemoptysis, rigid bronchoscopy is not just diagnostic, it is also a therapeutic. Now you have done all these procedures, still patient is having persistent hemoptysis. So what are the options available with me? So write down in persistent hemoptysis. In persistent hemoptysis. The options available in persistent hemoptysis. So 1, blocking the culprit artery. Bronchial artery embolization. Bronchial artery embolization. Next, if at all there is a localized disease, for example, left lower lobe bronchiectasis, it is frequently getting infected and there is hemoptysis. In such conditions, we can go for resection of affected lobe. Resection of affected lobe. Resection of affected lobe. Now my question is, why we frequently go for bronchial artery embolization, not pulmonary artery embolization? Now who will answer this question? Why frequently we go for bronchial artery embolization, not pulmonary artery embolization? There are two reasons. Say, I will tell all my students that medicine is not a rocket science. Most of you feel medicine is something difficult, it is something equivalent to rocket science. But according to me, medicine is equal to common things. You should know what is common. Common science. Along with that, most important, some common sense. If you want to achieve as a good practitioner in medicine, it is not the theoretical knowledge that you should have, it is the clinical knowledge that you should have. Clinical knowledge is not dependent upon the amount of books you read, it is dependent on the amount of things that you see. So medicine is combination of common things, common science and common sense. See, 90% of patients coming to you will be having only this. So if there is a shortness of breath, you should evaluate for the first 10 common causes instead of last 10 uncommon causes. Okay. So write down. Why bronchial artery embolization? Bronchial artery embolization only done. See, most common is bronchial artery. It's not pulmonary artery. Second thing, which takes part in gaseous exchange, it is not bronchial artery, pulmonary artery. If you embolize pulmonary artery, patient will develop hypoxemia. So two reasons. Most common source is bronchial artery. In majority, bronchial artery will be reason. And second thing, out of bronchial artery and pulmonary artery, which will take part in gaseous exchange, it is pulmonary artery. So there is no logic in embolizing pulmonary artery, which will later result in hypoxemia. But very rare situations, about 1 in 1 lakh situations, whenever there is a small pulmonary artery aneurysm, so that localized branch can be embolized. So generally we don't go for embolization of a large branch of pulmonary artery. So very, very important for all practical purposes. If they ask you that you want to embolize one artery in hemoptysis, your answer by common things and common sense will be bronchial artery embolization only. Pulmonary artery embolization, whenever there is an aneurysm in the subsegment, in such situations that subsegment can be embolized, but that is very, very rare. So by now I would have seen more than 20,000 cases of hemoptysis. In no case we have referred for pulmonary embolization. Very rare, no need to worry. Now out of these two methods, out of bronchial artery embolization and out of resection of affected lobe, which is most preferred nowadays? Whenever there is a non-surgical method, we prefer it commonly. So this is most preferred method overall. See why this is most preferred? Because resection of affected lobe is an invasive surgery and most of the patients might be having comorbidities. Again, recovery during post-op period is also a big issue. So whenever there is a non-surgical method giving good benefit, we generally prefer that method only. So students, in persistent hemoptysis, for all practical purposes, we go for bronchial artery embolization only, and that is considered as most preferred method nowadays. Most preferred method nowadays. Now let us see a hemoptysis case. Now you were a duty intern in the emergency room. Now you got a call from the ward that there was a 54-year-old female. She was having non-endobronchial carcinoma of her left main stem bronchus. So she developed massive hemoptysis while hospitalized. So you were called by the duty nurse. Now you went to see the patient. Now nurse disappeared. Now all of the following should be considered in the management except. Now you are there with a patient with massive hemoptysis. All can be considered in the management except. All can be considered in the management except. So tell me students, what can be considered? Yes. So all can be considered in the management except. See, can you consider bronchial artery embolization at some point of time? Yes. Early bronchoscopy, you can call me the consultant for doing early bronchoscopy. Now you are there with the patient. What can you do there immediately? Placing the patient in lateral decubitus position with her left side down. So is it really helpful? Is it really helpful? Let us see. Now in this patient, she is having disease on the left side. She is having disease on the left side. Whenever there is massive hemoptysis, one important point in stabilization is you should place bleeding lung down. You should place bleeding lung down. And why it is done? To protect healthy lung. To protect healthy lung. So how will it protect healthy lung? Now this is right, this is left. Now if you put the patient in left lateral decubitus position, so this is the diseased lung. So whatever bleed is happening, it will accumulate in that lung by gravity. So the other lung will be open for ventilation. So till the consultant comes and he does an procedure such as bronchoscopy, this can give you some time to save the life of the patient. So in massive hemoptysis, when you know the diseased side, so when you don't know the diseased side, you cannot do anything. So you should just pray the God and you should stabilize the patient in supine position. When you know the diseased side, you should protect the healthy lung by placing bleeding lung down. So protect the healthy lung, And this is also to be considered. Then vigorous coughing maneuvers. So you should not ask the patient to vigorously cough. So whenever patient vigorously cough, positive pressure can be developed in the thoracic cavity, which can result in more rupture of the blood vessels. So that's why in hemoptysis, we ask the patient to calm down. We ask the patient to relax, and we also prescribe cough suppressants. Here vigorous coughing maneuvers is not indicated. What can be considered? Bronchial artery embolization, early bronchoscopy, placing the patient in lateral decubitus position with her left side down can be considered. Coming to some basic histology of the lung. To understand diseases, you should know the histology at the level of alveoli especially. Consider this is your alveoli. So alveoli is lined by two types of cells. So we have type 1 pneumocytes. So these were considered as pavement epithelium. And these cover majority of alveolar surface area. These cells cover majority of alveolar surface area. So these cells, they cover majority of alveolar surface area, and these are easily damaged. They are vulnerable to injury. Whereas type 2 pneumocytes, what is the important function? They secrete surfactant. Type 2 pneumocytes, the important function is secrete surfactant. So J. Patel, lignocaine nebulization to decrease cough, it can be given, but it is not a definitive measure. It can be given, but it is not a definitive measure. So by giving lignocaine nebulization, if you miss keeping the patient in left lateral position in that situation, if I am the consultant, so I am going to scold you like anything. So first is not nebulization, keeping the patient in left lateral position. After that, you can give whatever you want. You can give lignocaine, you can give dextromethorphan, you can give codeine, whatever you want you give, but that is not recommended in any book. Recommended is protect the healthy lung by placing bleeding lung down. If you want, you can give lignocaine nebulization. So secrete surfactant. So the important function is to secrete surfactant, and this is majority. The cells are majority in number. So majority in number. By number, which cells are majority? Type 2 cells are majority. And next important thing, these have capacity to divide. So this can divide and give rise to. Type 1 cells, and because of that, type 2 cells are also called as precursors of type 1. So point to remember here, students, these type 1 pneumocytes, whenever there is alveolar injury, they are easily damaged and they have no capacity to regenerate. It is type 2 cells which will divide and give rise to type 1. That's why type 2 cells were historically also called as precursors of type 1. Write down this statement from Harrison. So what is this? Usually during alveolar injury, type 1 easily damaged. So type 1 cells easily damaged, and type 2 proliferation will be seen. So this is something regularly happening. Whenever there is alveolar injury, type 1 cells easily damaged and type 2 proliferation will be seen. But in bad diseases such as ARDS, both type 1 and type 2 damaged, because both the cells are damaged, because there is extensive damage. These patients will have poor prognosis. So generally, whenever there is an alveolar injury, type 1 cells easily damaged and type 2 proliferation is seen. But in ARDS, there will be extensive damage of alveolar cells, because both type 1 and type 2 are damaged. These patients generally will carry poor prognosis. These patients generally will carry poor prognosis. So this is one of the reasons why patients with ARDS generally carry poor prognosis. Next we will discuss physiological concepts in respiratory medicine. Even though they will be discussed in your integrated physiology, only if you understand these concepts, you can understand a few respiratory diseases. Yes, any ARDS, Ruchir Desai, in ARDS also, in COVID also there will be ARDS. So that is the reason why COVID ARDS is again having poor prognosis. So let us discuss some physiological concepts in respiratory medicine. Only if you understand this basic physiology, you can understand the diseases, particularly these obstructive lung diseases, pushing lesion, pulling lesion, clinical scenario based questions. So write down first physiological concept in respiratory medicine. Around your lung there is a covering called as pleura, and always within the pleural space there is a pressure. So that pressure is called as intrapleural pressure. So write down first physiological concept. First physiological concept, it is intrapleural pressure. First physiological concept, it is intrapleural pressure. So write down students, intrapleural pressure. My lung always tries to recoil towards the center. My lung always tries to recoil towards the center. Now how to explain this? Consider you are having a spring in your hand, you are stretching it to some distance and you are keeping on this table. After some time, will that spring be still in stretched position or will it come back to its normal position? It will generally come back to its normal position. The reason is simple. Any elastic substance has an inherent property to recoil. In the same way, your lung is also a good elastic structure. Its tendency is always to recoil towards the center. And they have noticed chest wall's tendency is to move outward. Chest wall's tendency is to move outward. If these two phenomena are routinely happening, your inspiration and expiration will not be comfortable. In between these two opposite forces, God has created a balancing pressure which brings lung to an equilibrium position and chest to lung to an equilibrium volume and chest wall to an equilibrium position, so that your inspiration and expiration is comfortable. So in Harrison, they don't mention God created this. They mention nature created this. So they also don't know how it was created. So in Harrison, they have clearly mentioned nature created a pressure to bring lung to an equilibrium volume, chest wall to an equilibrium position, so that inspiration and expiration are comfortable. In between these two opposite forces, there is a balancing pressure. There is a balancing pressure. So this balancing pressure is called as negative intrapleural pressure. Now what is this negative? See, actually this intrapleural pressure is not real negative pressure. When they measured this pressure, it was slightly less than atmospheric pressure. In respiratory physiology, we take reference atmospheric pressure as 0. So anything less than 0 is considered as negative. Anything more than 0 is considered as positive. Actually, it is not a real negative pressure. It was slightly less than atmospheric pressure. But in respiratory physiology, we take reference atmospheric pressure as 0 for calculation convenience. Anything less than 0 is negative. Anything more than 0 is considered as positive. So write down, this intrapleural pressure is having only one function, always tries to maintain, it always tries to maintain equilibrium lung volume, and this equilibrium lung volume is called as relaxing volume, also called as functional residual capacity. So what is this functional residual capacity? When we discuss spirometry, you will know it. This intrapleural pressure has only one function: to maintain equilibrium lung volume, also called as relaxing volume, also called as functional residual capacity. And when they measured this pressure, it was not uniform throughout the lung. At the apex, it was found to be more negative when compared to base. When they measured this pressure, they found out in the apex it was more negative when compared to base. They thought that this difference was due to influence of gravity, but exact mechanism is not yet clear. When they measured this pressure, they found out at the apex it was more negative when compared to the base. They thought that this was due to influence of gravity. Exact reason is not yet known. So point to know here is, students, in all of us, in you, me, everybody, there is a pressure around your lungs called as intrapleural pressure, which is generally negative. And what is its function? To maintain equilibrium lung volume. So this is something normally happening in all of us. Now let us see the abnormality. Let us see conditions associated with more negative intrapleural pressure, less negative or positive intrapleural pressure. First we will discuss the physiological conditions. Then we will go into the pathologies. Make a table, students. More negative intrapleural pressure on one side, less negative or positive intrapleural pressure. Here the reason is deep inspiration, more negative intrapleural pressure. Less negative or positive, it can be due to physiological condition, forced expiration. And you must be knowing forced expiratory maneuvers, cough, and Valsalva maneuver. Valsalva maneuver is also a forced expiratory maneuver. Basic principle here is, to understand respiratory physiology, you should know school level physics. Whatever you have learnt in your secondary school, that much physics is sufficient. See, any gas will follow basic laws of physics. Now first let us see what is the reason for more negative intrapleural pressure in deep inspiration. You must be knowing this basic law of physics that gases generally flow from high pressure to low pressure. Now whenever somebody is doing deep inspiration, now all those gases from the atmosphere has to reach your lung. To accommodate excess gases into the lung, what should happen to the pressure around your lung? It should become more negative. By law of physics, during deep inspiration, to accommodate excess gases into the lung, it should become more negative. So Harshit Agarwal, don't get confused between centimeter H2O and mmHg. So for pleural measurement, they will be nearly the same. Okay. So it will be nearly the same. So if you have any doubt, you can refer Ganang textbook. So in Ganang and Guyton, they have given these values. So it is a range. Harshit Agarwal, in your body anything can be a range. So 2.5 to 4. and 7 to 10. So we have taken the upper limit and lower limit, Harshit Agarwal. Okay. So don't get confused between mmHg and centimeter. They will be nearly the same. So just understand the trends. So what happens during inspiration, what happens during expiration. So deep inspiration, so by law of physics, to accommodate excess air into the lungs, the intrapleural pressure becomes more negative. Now coming to forced expiration. Now if you take consider I am giving you a balloon completely filled with air. So now I am asking you to expel the air out without breaking that balloon. What will you do? You will press the balloon. So by pressing the balloon, you are applying positive pressure around the balloon. In the same way, now your lung is filled with excess air. Now I want to do forced expiration. If air has to come out forcibly from the lung, if air has to come out forcibly from a fully inflated balloon, what you are doing? You are applying positive pressure. In the same way, around your lung, a positive pressure will be generated. So during forced expiration, just like pressing the balloon, your intrapleural pressure will become positive, pushing the air out rapidly. Then cough. Cough is nothing but forced expiration. Cough is also forced expiration, and the definition of cough: forced expiration against closed glottis. What is Valsalva maneuver? So Valsalva maneuver is a forced expiration against closed mouth and closed nose. So this is also ultimately forced expiration only. So deep inspiration will have more negative intrapleural pressure. Forced expiration and forced expiration maneuvers, cough, Valsalva maneuver, will have less negative, usually positive intrapleural pressure. These are physiological conditions. Now let us see pathological conditions. So pathological conditions called as pushing lesions. See, from now onwards it will be simple English. So don't get confused even after reading simple English. So simple English, push means this, pull means pulling. So there is no controversy. So majority of the students, sir, I am always getting confused. What is push, what is pull? Push means pushing, pull means pulling, simple language. So pushing lesions. Pushing lesions that we come across will be pleural effusion. Pneumothorax. Normally within the pleural layer, within the pleural space, there will be about 5 to 10 ml of fluid. Now instead of that, if 1 liter of fluid accumulates, that fluid can generate a positive pressure. So that positive pressure will push the mediastinum to opposite side. So that filling of fluid in the pleural space is called as pleural effusion. Now instead of fluid, if air accumulates, it is called as pneumothorax. Air can generate still more positive pressure and push the mediastinum to opposite side. Because disease is responsible for push, these are called as pushing lesions. Write down mechanism, you will understand. Excess fluid or air accumulated, can generate positive pressure resulting in push of mediastinum to opposite side of disease. So very simple language. Excess fluid or air accumulated, it is going to generate positive pressure. and that positive pressure can push mediastinum to opposite side of the disease, Now tell me students, if there is right-sided pleural effusion, what will be the tracheal position? Towards the left. If there is left-sided pneumothorax, what will be the tracheal position? Right. So how do you identify the mediastinal position, tracheal position? Up exhibit. Because disease is pushing the mediastinum. It is called as pushing lesion. So in simple words, if patient is having right-sided pleural effusion, trachea will be towards the left. If patient is having left-sided pneumothorax, trachea will be towards the right, that is opposite side. Now whenever there are pushing lesions, there should also be pulling lesions. Now what are the pulling lesions that you come across? One is collapse and other is fibrosis. Now let us see why they are pulling lesions. What is common here? Now what is meant by collapse, students? I have already told you what is meant by collapse. Collapse means a part of lung is not at all containing air. So when a part of lung is not containing air, what will happen to total volume of that lung? It will decrease. Then what is fibrosis? Now suppose there is an injury to skin. After some times there will be deposition of scar tissue. Now tell me students, this deposition of scar tissue, will it cause expansion of that area or shrinking of that area? Deposition of scar tissue will cause shrinking of that area, hardening of that area. In the same way, whenever your lung is damaged, ultimately there can be deposition of scar tissue. Because of that scar tissue, your lung shrinks, your lung becomes hard. So that phenomena is called as fibrosis. Okay, because your lung is shrinking, it is becoming hard. What will happen to total volume of that lung? It will be reduced. So let it be collapse or fibrosis. Ultimately there is volume loss. These two diseases are also called as volume loss lesions. Now by common sense students, whenever there is volume loss, what is the pressure around your lung always trying to maintain equilibrium lung volume? It is your intrapleural pressure. So whenever the lung volume decreases, now your intrapleural pressure as a defense mechanism will try to expand this lung. So whenever it wants to expand this lung, what pressure it should generate? It should be more negative pressure, because positive pressure is compressing pressure which will empty out the lung. Negative pressure is the expanding pressure. So write down, whenever there is volume loss, to maintain equilibrium lung volume, okay, more negative intrapleural pressure generated, that results in pull of mediastinum to same side of disease, pull of mediastinum to same side of disease. Because of more negative intrapleural pressure, the mediastinum will be pulled towards the same side of the disease. Now if there is right-sided fibrosis, what will be the position of trachea? It will be more towards the right. If there is left-sided collapse, what will be the position of trachea? It will be more towards the left, because disease is responsible for pull. It is called as pulling lesion. Now my next question is, I have given you a patient for clinical examination, and this patient was having a disease on one side. I have not revealed whether it is right side or left side. Now by inspecting the patient, by just seeing the patient, how will you tell the diseased side? So to identify the diseased side, what is most important finding, students? To identify diseased side, what is most important finding? Don't say it is tracheal position. Why tracheal position is not the important finding? Very simple. If there is left sided trachea, it can be either due to right pushing lesion or left pulling lesion. Right pushing lesion or left pulling lesion. Then what is the most important finding to identify the diseased side? Very simple. Consider this is healthy hand. This is diseased hand. Which will always move better? Healthy hand will always boom better. In the same way, healthy lungs will give good chest wall expansion, whereas on the diseased side there will be no proper chest wall movement. So write down, very important clinical finding to identify diseased side. To identify diseased side, always localize side of decreased chest movements. Always localize side of decreased chest movements. Very good, Sneha. To identify diseased side, always localize side of decreased chest movements. Now I'll give you a clinical scenario. Try to answer this. There was a 50-year-old male. Okay. He came to my clinic, and on examination I have found out his trachea was towards the left. His chest movements were decreased on right. What can be the possible diagnosis? What can be the possible diagnosis? Tell me the answer, students. What can be the possible diagnosis? Yes. What can be the possible diagnosis? So trachea is on the right. Trachea is on the left. Whereas movements have decreased on right. So what can be the possible diagnosis? Trachea left, movements decrease. First tell me the diseased side. Is it right sided disease or left sided disease? Because movements are decreased on right, it is a right sided disease. It is a right sided disease. Okay. And is it a pushing lesion or pulling lesion? Because trachea is towards the left. It is a right pushing lesion. Probability of either pleural effusion or pneumothorax. Now how to exactly differentiate? Just percuss. If you get a very dull note, it is suggestive of fluid. If you get a very resonant note, it is suggestive of pneumothorax. We will again have a special session on clinical examination. Till then, you should know what is pulling lesion. You should know what is pulling lesion, what is pushing lesion. And very important, to identify diseased side, you should always localize side of diminished chest movements. In the given case, it is a right pushing lesion. Either possibility of pleural effusion or pneumothorax. So we'll take break for 15 minutes. Any doubts up to now, you can ask me. I'll be here for another few minutes. Now you can ask me your doubts, students. Yes, students, any doubts you can type now. Sir, please tell about fiber optic bronchoscopy. Causes of hemoptysis slide. See, Namita, fiber optic bronchoscopy is a device. Okay, I'll show you here. Namita, I know it was difficult time for you all in COVID. You must have not seen basic bronchoscopies, anything like that. So this is a slender tube like this. It is made up of fibers and it has a optic piece to visualize. So fiber optic bronchoscope is a device which can be put into your bronchus and visualize the lungs. So Bishaul Rai, what happens usually in alveolar injury? So I don't know again why it is simple English you are unable to understand. During alveolar injury, type 1 cells easily damaged and type 2 cells will be proliferating. So Bishaul Rai, why chest movements is standard? Very simple Bishaul Rai. Your right hand and your left hand, one is damaged. How will you tell which hand is damaged? You will ask just the patient to move his hand. So whenever anything is damaged, that will not move properly. See, apart from that, in medicine you need a simple finding. So which is damaged, that will not move properly. So Yasser Arafat, why negative pressure pulls the trachea? See, I think you must be knowing simple physics. So positive pressure is a pushing pressure, negative pressure is a pulling pressure. See, whenever you put a straw into cool drink, so you are pulling the drink up. So are you applying positive pressure or negative pressure? Yasser Arafat, simple common sense. So you are putting a straw into a cool drink and you are sucking it. So sucking it is a negative pressure or positive pressure, and you are blowing air into it. Is it positive pressure or negative pressure? Blowing out is positive pressure. Always sucking pressure is negative pressure. So negative pressure is generally a sucking pressure. So it will suck the contents into it. So Pratima Mahananda Prahalad, please explain intrapleural pressure. See, intrapleural pressure is the pressure created by nature to maintain equilibrium lung volume. So normally your lungs tendency is to recoil towards the center. Chest wall will move outward. So to balance it, so there is a pressure in between. So suppose there is husband and wife, okay, they are fighting. So now to bring them together, there must be a mediator, there must be a counselor. So to bring them together, or a girlfriend and boyfriend is fighting, in between them to bring them together, there will be a friend. So in the same way, your lung will be going this side, your chest wall will be going outside. So that mediator, that friend which brings lung to an equilibrium position, chest wall, lung to an equilibrium volume, chest wall to an equilibrium position is intrapleural pressure. So it is a pressure created by nature to bring these together. So Chanchal, in case of hypoxia, hyperventilation can cause respiratory alkalosis. How much till it takes to occur? So it depends upon patient's respiratory effort. If patient is anxious, respiratory alkalosis, it can happen within minutes, 5 to 10 minutes. If patient is not that anxious, if his respiratory effort is not that pronounced, it will take hours. So D Manasa, in ARDS, first endothelium affected or pneumocytes. So generally it is type 2 cells. Directly the type 2 cells has ACE2 receptor. So the virus can come and attach to type 2 receptor and then can damage. So why bronchiectasis? Left lower segment. So causes of hemoptysis. So this is the causes. See, we have understood that bronchiectasis is more on the left side. So there is upper part and lower part. So just by common sense, who has asked this question? Nival Ota. There are secretions in the upper lobe. There are secretions in the lower lobe. If patient is having some cough reflex, the upper lobe secretions can easily drain out because the distance between upper lobe and your oral cavity is less. So don't ask me why the distance between lower lobe and oral cavity is more. So if you measure also, the distance is more. So from the upper lobe the secretions can easily come out. From the lower lobe it is very difficult. For bronchiectasis to happen, secretion should stay there and secretion should result in infection. So this is the vicious cycle that we have discussed. See here. So there should be stasis of secretions. If it is lower lobe, the stasis will be more. The clearance will be problematic. So infections, inflammation, destruction, dilatation, ultimately resulting in bronchiectasis. Okay. So I hope whatever questions you have asked, I have given you the explanation. So Yasser Arafat has asked a basic concept of physics. Always negative is a sucking pressure. Positive is generally a pushing pressure. That is basic law of physics. So you can also see it in your real life when you put a straw and suck inside. So when you take something inside, you are applying a positive your negative pressure. So Chanchal, if you are having a good neonatologist, they can sustain. So if you take him to a good neonatologist, Chanchal, baby born before 20 weeks, they will try their best. But very difficult, but they can try. So in medicine, there is no 100% guarantee for anything. Okay. Will a baby sustain? It depends upon the care. So usually it will not sustain. And below 20 weeks, I don't think it will have even also vital organ function. So I think only after 24 weeks there will be viability. So just asking below 20 weeks, it will not be a possibility. So but there are few situations when there was last LMP period wrong. So actually patient will be saying only 20 weeks, actually baby will be 24 or 26 weeks, they will sustain. So Simran Pachnanda, lower for community acquired pneumonia, there is no predisposition. So community acquired pneumonia, so there is no specific segment that this only will involve. So it is only for aspiration pneumonia. It is clearly written now. Pneumonia happening after aspiration, usually from the oral contents. So for community acquired pneumonia, there is no predisposition. So welcome back, students. Next physiological concept is airway resistance. So write down, next physiological concept is airway resistance. Again, this is basic school level physics. So write down, airway resistance is resistance to flow of airway by the respiratory tract during inspiration and expiration. During inspiration and expiration, there will be resistance of the respiratory tract to airflow during inspiration and expiration. This is called as airway resistance. And you must be knowing simple law of school level physics. Resistance is proportional to 1 by radius to the power of 4. Resistance is proportional to 1 by radius to the power of 4. It means whenever there is airway narrowing, automatically there will be increased airway resistance. The concept here is whenever there is airway narrowing, students, automatically there will be increase in airway resistance. Now, what are the diseases responsible for airway narrowing? First is asthma. You know that asthma is an allergen mediated disease. So this allergen, when reaches your lung, will result in an inflammatory response. Because of this inflammatory response, there will be production of mediators called as histamine, serotonin, leukotrienes. And what is the function of these mediators on your lung? It will result in bronchoconstriction. Asthma is an allergen mediated inflammation. Whenever allergens reaches your lung, it can result in an inflammatory response. Because of that inflammatory response, there will be few mediators such as histamine, serotonin, leukotrienes. These mediators can be responsible for bronchoconstriction. Second important disease is COPD. In COPD, most important subtype clinically for airway resistance is emphysema. So why in COPD emphysema the airway resistance increases? For that you should know some basic lung physiology. So it is a complicated topic. I will discuss in detail in the next slide. Before that, some basic respiratory physiology. Now tell me, students, in respiration there are two phases. One is inspiration and other is expiration. In a normal individual, which is slightly prolonged? Just answer, is inspiration or expiration? Which is slightly prolonged in a normal individual? Let us see how many of you know the right answer. Which is usually prolonged? Is it inspiration or expiration? So I'll give you a clue. Inspiration is an active process. Expiration is a passive process. Because inspiration is an active process, my body is applying energy. So generally inspiration will be quick. Expiration will be bit delayed. So write down, inspiration is an active process. So very good, Palak. Expiration is prolonged. Inspiration in general is an active process, whereas expiration is a passive process. When compared to inspiration, expiration slightly prolonged. See here, because inspiration is an active process, my body applies energy. So inspiration will be quick, whereas expiration is a passive process dependent on only lung recoil. So it will be bit slower. In a normal individual, if inspiration, excellent, many of you have answered it correct. In inspiration, in a normal individual, if it is for 2 seconds, expiration can be 3 seconds. Total duration is 5 seconds. So like that, how many cycles can happen in 60 seconds? 12. That's why normal respiratory rate is 12 to 15 per minute. In a normal individual, inspiration when compared to expiration is a bit short. So normally expiration is prolonged. So very important statement. When compared to inspiration is short, expiration is slightly prolonged normally itself. Now next question. Now suppose there is an obstruction in the airway. During which phase this obstruction will be more predominantly seen? Is it during active expanding phase called as inspiration or passive closing phase called as expiration? See here, if there is an obstruction in the airway during inspiration, because it is an active process, body will apply energy, so it will open and it can overcome the obstruction. Whereas expiration is a passive closing phase. It is a passive, body has no energy. So during expiration, the obstruction will be more pronounced. That's why if I give you my stet and ask you to auscultate for a sound called as wheezing, which indicates airflow limitation, during which phase you will see it clearly? Expiration. So write down, during expiration, obstruction of airway more seen, and that is the reason why there is expiratory wheezing. So everybody has answered it correctly. Two important points. Expiration is slightly prolonged in all of us. If at all there is an obstruction in the airway, the obstruction will be more pronounced during expiration. That's why whenever I give my stet to you to auscultate for wheeze, when will you find it more commonly? During expiration. Now with this basic concept, let us see pathophysiology of COPD emphysema. So write down pathophysiology of emphysema. First let us see what is normally happening. Normally at expiration, alveoli will be partially open. Why is alveoli partially open? Because within the alveoli there is a substance called as surfactant. Along with that, airways connected to the alveoli are also kept partially open at expiration, because around the airways there are some elastic fibers whose function is to apply outward traction. Elastic fibers, their function is to apply outward traction. So write down. So these elastic fibers apply outward traction to keep airway open. The concept here is, normally in all of us students at expiration, the alveoli are partially open due to surfactant. The airways connected to the alveoli are also open. So why they are open? Because there are elastic fibers which apply traction to keep airway open. Now suppose this patient has developed COPD emphysema. What is the most common cause? Most common cause is smoking. Along with that, alpha-1 antitrypsin deficiency. These are the two conditions, very important, which can result in COPD emphysema. Let it be any of this condition, ultimately there will be increased elastasis in the lung. Let it be any of this condition, ultimately there will be increased elastasis in the lung. And whenever there is ongoing smoking or ongoing lung damage, there will be also accumulation of inflammatory cells. Whenever there is an ongoing pathology, there will be accumulation of inflammatory cells in the lung. First, let us see what these elastases are capable of doing. Simple common sense. What is the function of elastase anywhere? To destroy elastic fibers. These elastases tend to destroy these elastic fibers. Now what was the function of these elastic fibers? To keep airway open at expiration. See, if this is the alveoli, let this be the airway. So to keep the airway partially open at expiration was a function of these elastic fibers. Now what will happen once the elastic fibers are destroyed? These airways close early during expiration. So when the elastic fibers are damaged, these elastic fibers are getting damaged, there will be early closure of airways during expiration. Whenever these airways are closing early during expiration, air from the alveoli is not going out. Air gradually gets trapped in the alveoli. So there will be air trapping. Very simple concept. Observe here, students. Normally, let your alveoli have 100 units of air. Say this 100 units has to go out during expiration. So when will it go out? So whenever the airways connected to them are also staying open. So for this 100 units to go out, so at expiration, these airways should be partially open. So whenever airways are closing early, instead of 100 units going out, only 50 units will go out. So how much is remaining in the alveoli? 50 units of air will remain in the alveoli. During the next inspiration, because it is an active process, 100 new units of air will come into the alveoli. Now how much is the volume of alveoli? 150. During expiration, again only 50 will go out because there is early closure. Now how much is left in the alveoli? 100 units. During next inspiration, another 100 units will come into the alveoli. Now how much is the volume of this alveoli? 200. During expiration, only 50 will go. Now how much is remaining in the alveoli? 150 units. Previously, with each respiration, not much was remaining in the alveoli. Now with each respiration, extra amount of air is remaining in the alveoli. Now once the alveoli is filled with excess air, after few years, all these alveoli will become over-distended air sacs. So these over-distended air sacs are called as bullas. See, as time progress, there can be more narrowing of the airway. So there will be more narrowing of the airway and your alveoli can be more distended. So these over-distended air spaces, these over-distended air sacs or air spaces, they are called as bullas. And why all this is happening? Because of damage to elastic fibers. Now this alveoli is containing more air. There will be increased residual volume. Whenever residual volume increases, automatically functional residual capacity increases. Automatically the total lung capacity increases. So alveoli are filled with excess air. So gradually the lung volume will increase. So the lung will not only expand sidewards, it will also expand antero-posteriorly. So whenever the lung is expanding antero-posteriorly, so what is this phenomena of increased AP diameter called as? It is called as barrel-shaped chest. See, the lung is becoming big. It will not only expand sidewards, it will also expand antero-posteriorly, resulting in a phenomena called as barrel-shaped chest. Now if you notice here students, initially this was the radius. Now what has happened to the radius? It has decreased. So there is decreased airway radius. Whenever airway radius decreases, automatically there will be increased airway resistance. And simultaneously we have forgotten about these inflammatory cells. These inflammatory cells which have reached the lung, they can involve the alveolar walls. So these inflammatory cells will not keep quiet. They will be causing inflammation and involvement of alveolar walls. These inflammatory cells can cause involvement of alveolar and capillary walls. Once these alveolar and capillary walls are involved, it is filled with inflammatory cells. Normally your alveolar capillary wall, see your alveolar capillary wall should be very smooth like this. It should be very smooth for proper passage of gas. Now if it is filled with so many inflammatory cells, gases cannot penetrate and go into the circulation. So this results in decreased diffusion of gases. This is the pathophysiology. Now we have understood in COPD emphysema, the residual volume increases, functional residual capacity increases, total lung capacity increases, and overall there will be increased lung volumes, decreased airway radius, increased airway resistance. As time progresses, these inflammatory cells will involve the smooth alveolar capillary membrane. Whenever it is filled with inflammatory cells, now it will not allow proper diffusion of gases. That can result in decreased diffusion of gases. Now let us see, because of this pathophysiology, what will happen in a real patient. Now let us apply this to a real patient. So this is what happens to his chest wall. What is this phenomena? Increased AP diameter. I told you I am going to introduce you a real life COPD patient, fully blown out COPD patient. This is how he appears in the emergency department. You can notice there is increased AP diameter because gas exchange is not happening properly in his body. He will be having breathing difficulty. Now let us see what are those gas exchange abnormalities. Because the alveolar capillary membrane is damaged, oxygen might feel difficult to go inside the body. So this patient will have decreased transfer of oxygen across the alveolar capillary membrane, resulting in hypoxemia. Now we have understood that in this patient there is air trapping during expiration. So I have written here, there is air trapping in this patient. Now when it is happening during expiration, normally during expiration, which gas should go out, students? Carbon dioxide. I think you must be knowing this basics. During inspiration, oxygen will come into the body. During expiration, carbon dioxide will go out. Because now the gas which has to go out, it is getting trapped in the body. This patient will develop increased CO2 in the blood. This phenomena is called as hypercapnia. And moreover, to worsen this gaseous exchange, this patient will also have diaphragmatic impairment. Now what is this diaphragmatic impairment? Why the diaphragm is not functioning properly? You must be knowing strongest respiratory muscle in your body is diaphragm. So why is respiration happening properly? Thanks to diaphragm. So diaphragm is the strongest respiratory muscle. Now in a normal individual, so this is the lung. So this is the size of the lung. It is comfortably sitting on the diaphragm. It is not applying any extra weight. Now a COPD lung will be like this, a big lung. So this big lung can apply weight on the diaphragm. So whenever it applies weight on the diaphragm, now diaphragm is also a muscle. When you are applying more weight on it, it cannot move properly. So when diaphragm is not moving properly, the patient's respiratory effort can decrease. So if respiratory effort decreases, insufficient inspiration, patient's inspiration will not be proper. Oxygen coming into the body will be less. Insufficient expiration. Carbon dioxide going out from your body will not be proper. So CO2 will increase in the body. So this diaphragmatic impairment due to big lungs on the diaphragm will not allow the diaphragmatic movement properly, and it will worsen the gas exchange abnormalities. So ultimately, patient will be having less oxygen and less carbon dioxide in the body. Less oxygen and less carbon dioxide. But to know exactly the oxygen levels and carbon dioxide levels, you should do ABG. ABG means arterial blood gas analysis. But in majority of emergency departments, ABG may not be available. How will you indirectly know the oxygen status? By patient's SpO2, by seeing a pulse oximeter. Suppose this patient is having SpO2 of 75%. So because oxygen is less in the body, his SpO2, say it is 75%. Normal value is generally 94 to 96%. Now whenever there is a patient with low SpO2, what will be your next step? What will you do as an intern? You generally dump oxygen in him. You put so much of oxygen in him and you try to bring the SpO2 to normal value, 94 to 96%. Now can the same practice be followed in a patient in COPD? Tell me yes or no. So can excess oxygen be given in COPD to bring SpO2 to normal value? To bring SpO2 to normal value, yes or no? Can you give excess oxygen in COPD? Can you give excess oxygen in COPD to bring SpO2 to normal? Yes or no? Yes or no? The answer is big no. In COPD, never you should give excess oxygen, never you should bring the saturation to normal value. Now what is the reason behind this? When compared to other respiratory diseases, COPD is a separate disease. It is Amitabh Bachchan of all respiratory diseases. It is Amitabh Bachchan of all respiratory diseases. So why it is so? I will tell you the reason. Amitabh Bachchan has been acting since 40 to 50 years. So COPD is also a disease which takes 20 to 30 years to happen. Patient has to smoke for 20 to 30 years. And even after developing the disease, patient can stay with the disease for another 10 to 20 years. In such big duration, now COPD itself has created a legendary name for itself. So patient is going to live with COPD for around about 20 to 30 years. So in such large duration of disease, long duration of disease, there will be some permanent changes happening in your respiratory receptors. So generally your respiration happens because of two stimulus. See, whoever are not clear with basics, kindly listen this topic carefully. Again, don't ask me, sir, what is hypoxemia, what is hypercapnia? Just spend 5 minutes, it will be clear. See, respiration happens either because of hypoxemic drive or because of hypercapnia. See, the stimulus is less oxygen or more CO2 for respiration to happen. Generally, your peripheral chemoreceptors takes care of hypoxemic respiratory drive. Your central chemoreceptors takes care of hypercapnic respiratory drive. So hypercapnia taken care by central chemoreceptors. Hypoxemia by peripheral chemoreceptors. In COPD, there is both hypercapnia and hypoxemia. First, let us discuss regarding hypercapnia. Because of chronic hypercapnia, always the receptors are getting stimulated. Now, suppose there is a switch like this. If you continuously press this switch all the time, after some time, the switch will lose its function. So, because of continuous stimulation of central chemoreceptors, your central chemoreceptors will become tired and they will announce retirement after a while. So the central chemoreceptors will stop functioning after a while. Now your breathing is only taken care by peripheral chemoreceptors. See, your peripheral chemoreceptors are very loyal to your body and they fight till the last breath. See, it is just like a human's tendency. So few people will give up very early when you give them a work, whereas few people will fight till the last breath. So this peripheral chemoreceptors are very durable, just like Amitabh Bachchan. They will be working always. They are not like Abhishek Bachchan, who stopped acting for God's sake, for the benefit of us very early. So this peripheral chemoreceptors will fight till the last breath. So they are fighting till the last breath. Now if you give excess oxygen, so and correct the oxygen level, now there will be no hypoxemia. So already central chemoreceptors are not functioning. Now peripheral chemoreceptors are also not functioning. Patient will not have stimulus to breathe. He will stop respiration. So if you give excess oxygen and if you bring the oxygen level to normal, what will happen, students? There will be loss of hypoxic drive that can result in respiratory arrest. So write down this mechanism given in Guyton. In chronic hypercapnia, CO2 level may not stimulate respiration properly. As years progress, central chemoreceptors will be tired and they will announce their retirement. These people keep breathing only because of hypoxic drive. So Amitabh Bachchan will be the only person earning for that home. Now if hypoxic drive is withdrawn by administering excess oxygen. So if you make Amitabh Bachchan sit at home, no need to work. Already Abhishek Bachchan is not working. Now Amitabh Bachchan is also not working. The house will be ruined. If hypoxic drive is withdrawn by giving excess oxygen, breathing may stop. Then what is the solution? Here? See, if you don't give oxygen, your other organs will not function properly. Kidney needs oxygen, heart needs oxygen, brain needs oxygen. Then what is the solution? Solution is low flow oxygen. Instead of giving 5 to 10 liters of oxygen, you give 2 to 3 liters per minute of oxygen and target SpO2. Here will not be 94 to 96. So just bring it to 88 to 92%. No need to bring it to normal. Just bring it to near normal. So when you bring it to near normal, always some amount of hypoxemia will be present. So which will enhance the respiratory drive and patient will be breathing. So in this scenario, students, don't give excess oxygen. Instead of giving excess oxygen, give him low flow oxygen. And target SpO2 should be 88 to 92%. You can see in the oxygen flow meter. So there will be numbers 1 to 15. So whenever you increase 5 to 10 liters, that is high flow oxygen. 2 to 3 liters, it is low flow oxygen. So Aish is there. So Aish is low flow oxygen. So she is the low flow oxygen for this home called as COPD. So this is Aish. So she will make both Amitabh Bachchan, she'll allow Amitabh Bachchan to work and she'll control Abhishek Bachchan. So low flow oxygen is Aishwarya for that home. So low flow oxygen should be given. It's not high flow. So very important, you as an intern never be hero in giving excess oxygen to a COPD patient, because it will make his respiration zero. Kindly remember this, students. Never try to be a hero by giving excess oxygen to a patient with COPD, because it can make his respiratory effort zero. So the rule is give him oxygen, but it is low flow, and the target SpO2 should be 88 to 92%. By giving oxygen, if you have the target 88 to 92%, you should be very happy that you have saved the life of the patient. So don't be a hero in giving excess oxygen to a patient with COPD, because it will make his respiration zero. So that is very important. Now let us see the chest X-ray features. Now this is a normal individual. So this is a normal individual's chest X-ray. You can see the lung fields, the normal lung fields, okay, and this is the curved diaphragm. So diaphragm will be curved, and your heart is also globular in shape. See, curved diaphragms, globular heart. So a normal chest X-ray. So you'll be very interested, because normal chest X-ray is generally curvy. Normal chest X-ray is generally curvy. See, Chanchal, ARDS is an acute phenomena. In acute phenomena, such changes will not happen, Chanchal. So ARDS is just like a newbie in the market. So he is just like Ayushmann Khurrana, or he is just like that Varun Dhawan. It's not Amitabh Bachchan. So COPD is different. It is legendary. It takes 40 years to happen. So that's why you have permanent changes in the respiratory receptors. So you cannot apply COPD, that is chronic, ARDS, acute. So then what happens in a patient with COPD? In a patient with COPD. So what do you notice here? What do you notice here, students? So first thing, bilateral, big lungs, hyperinflated lung fields. So bilateral, hyperinflated lung fields. Hyperinflated lung fields. And next we have flat diaphragms. So flat diaphragms. And the globular heart has become tubular heart. Tubular heart. Tubular heart. See why these changes are happening. See, previously in normal individual, see, this was the diaphragm, this was the normal lung size, and in this area, in this thoracic area, your heart was having a globular shape, Now what is happening in COPD? Because of increased weight on the diaphragm. So whenever you put excess weight on a curve, it tends to become flat. See, this is a curve. I have put weight on this excess weight. It becomes a flat. So your diaphragm, instead of being curved, it is flat and low lying. Now once the thoracic space increases, this globular heart will adjust like a tube. So three important changes. Bilateral, hyperinflated lung fields. Curved diaphragms becoming flat, low lying, and your globular heart adjusted like a tube. So three important findings in a patient with COPD. In a patient with COPD, bilateral, hyperinflated lung fields, flat diaphragms, and tubular heart. Now whatever you have learned up to now, students, I want you to apply it in a real life case scenario. So another patient in the emergency department, you were posted. So there was a 70-year-old male patient with known COPD. He has admitted to the emergency department with fever, purulent sputum, and increased shortness of breath. Whenever you find any patient with COPD, COPD with worsening. COPD with worsening. This phenomena is called as exacerbation, students. COPD with worsening. This phenomena is called as exacerbation. Now this is a patient with exacerbation and his initial SpO2 was 75%. True regarding the cases. Tell me, students, what is the true statement? See, nothing new. Whatever you have learnt up to now, try to apply here. So we'll go option by option. Chest X-ray shows shrunken lung fields, false. This is COPD, hyperinflated lung fields. Oxygen should be prescribed to hypoxemic patients, yes. Target SpO2 94 to 98, never. Target is 88 to 92. And supplemental oxygen should be given, yes. It did not demonstrate decreased mortality rates in patients with COPD. It is false. See, why we are giving oxygen? To improve vital organ function. Whenever oxygen is required, if you give oxygen, it can save the life of the patient and avoid mortality. That is the rule. Whereas option B, higher concentrations can blunt the hypoxic ventilatory drive causing CO2 retention. It is true statement. If you give excess oxygen, it will stop the ventilatory drive. When your respiration is not happening, oxygen will not come inside, CO2 will not go out. So CO2, because it is not going out, it can increase in the body. So there can be CO2 retention. So very good. Everybody has answered it as B. Yes, yes, yes. Thank you, Ram Pratap and Mondal, for your compliments. So you people are very interactive. If you are interactive, we will be more inspired and interested to teach better. So the answer is option B. Higher concentrations of oxygen blunt the hypoxic ventilatory drive causing CO2 retention. So that's why in the Western countries there is an oxygen alert card. Patients with COPD will be carrying that card. So whenever there is an aggressive intent, they will give the card to him. It will be clearly said, I am at risk of respiratory failure. Whenever I am ill, keep my oxygen 89 to 92%. If I need some nebulizer treatment for bronchodilators, give low flow oxygen. See, kindly don't be a hero by giving excess oxygen because it will make his respiration zero. So that's why they will be carrying oxygen alert card. So this is in Western countries. It is not going to happen in our country. Don't worry. Coming to mechanisms of hypoxemia. So let us see what are the basic mechanisms. So first is ventilation perfusion mismatch. Ventilation perfusion mismatch. So this was considered as most common mechanism. So many studies, so no specific reason, many studies have shown that ventilation perfusion mismatch is most common mechanism, students. Ventilation perfusion mismatch is most common mechanism. So other mechanisms of hypoxemia. So we have shunt mechanism, students. We have a diffusion defect and hypoventilation. So these last two, diffusion defect and hypoventilation, I will discuss separately in the topic respiratory failure. Again, tomorrow we have respiratory failure. There I will clearly tell you what is diffusion defect and hypoventilation. Now we will discuss in this slide ventilation perfusion mismatch. In the next slide, what is shunt. So write down ventilation perfusion mismatch. Before that, we all should know what is normally happening in us. Normally, students, if this is your alveolus, so your alveolus will be having a certain amount of ventilation. Alveolus will be having a certain amount of ventilation. And beneath the alveolus, there will always be capillary perfusion. And within the blood vessels, there will be certain amount of perfusion. And God, for proper functioning of our body, has created a ventilation perfusion balance. So for gaseous exchange to happen, this ventilation and perfusion should be matching, students. Now if you notice here, for two ventilations there are two perfusions. So for proper gaseous exchange to happen, the ventilation and perfusion should be matching. Now let us see conditions where there can be a mismatch. So important clinical condition is pulmonary embolism. So in pulmonary embolism, let this be the blood vessel, alveoli, and beneath that here you have blood vessel. In pulmonary embolism, there is no problem with ventilation. Alveoli will be having ventilation, but there is an issue with perfusion. So there is P here, and there will be blockage to pulmonary circulation. Pulmonary thromboembolism happens because of thrombus in the pulmonary artery. Now if you notice here, in a normal individual, two ventilations and two perfusions. But here a perfusion is absent because of a thrombus. So there will be ventilation perfusion mismatch. So previously ventilation and perfusion were matching. Now ventilation and perfusion will not match properly. So whenever there is ventilation perfusion mismatch, ultimately gaseous exchange will be affected, resulting in hypoxemia. So very frequently asked question, write down. In pulmonary embolism, where is the defect? Your answer should be perfusion. Pulmonary embolism, ventilation, there is no problem. Defect is in perfusion. Pulmonary embolism, ventilation, there is no problem. Perfusion, there will be a defect. So predominant defect in pulmonary embolism, is it ventilation or perfusion? It is a perfusion defect. Next important is COPD emphysema. COPD emphysema, it is a different phenomena. In COPD emphysema, there will be defect both in ventilation and perfusion, and it will be an asymmetric defect. So it will be an asymmetric defect. Both in ventilation and perfusion. Now what is that ventilation defect? Because of airway narrowing. See, airways are getting narrowed. So because of that, ventilation may not happen properly. And we also have discussed in COPD, there is involvement of capillaries, students. So whenever capillary walls are involved, see, the blood vessels are damaged, perfusion will also be affected. So in COPD, the defect is in both in ventilation and perfusion. So the defect is both in ventilation and perfusion. Because these defects are asymmetric, there will be ventilation perfusion mismatch. Frequently asked question. In pulmonary embolism, where is the defect? Predominantly in perfusion. In COPD, where is the defect? It is in both ventilation and perfusion. In COPD, the defect is both in ventilation and perfusion, and it is an asymmetric defect. Next we have shunt. Now tell me, students, what do you mean by shunt? Yes, what do you mean by shunt? See, shunt means some movement. Shunt means there is some movement. Now for example, whenever there is increased pressure in the ventricles of the brain, what is the surgery that they advise? Ventriculoperitoneal shunt. So you are diverting the pressure. In the peritoneal cavity by facilitating the movement of that fluid. Now whenever there is portal hypertension we advise a surgery called as portosystemic shunt. So you are trying to move that pressure from the portal circulation into the systemic circulation. So shunt anywhere means there is some movement. Shunt anywhere means there is some abnormal movement or some movement. Now shunt with respect to hypoxemia. So shunt with respect to hypoxemia, the textbook definition is there is movement of blood. There is movement of blood into circulation. There is movement of blood into circulation without oxygenation. If you keep this definition in your mind, understanding a shunt will be a cakewalk. Okay, so shunt with respect to hypoxemia. So I am just keeping it only with hypoxemia. So when do you call there is a shunt happening and resulting in hypoxemia? Whenever there is movement of blood into circulation without oxygenation. This shunt can happen at two levels. If it is happening in the heart and if it is responsible. See, why in COPD capillaries are involved? Because in COPD, I'll show you why capillaries are involved. So these accumulated inflammatory cells can damage the alveolar walls, can damage the capillary walls. So these inflammatory cells, because there is involvement of capillary walls, there will be decreased perfusion. This is the reason. So involvement of capillary walls by this inflammatory cells accumulated in the COPD lung. Okay. So we will take any other doubts in the last, because I have 3 topics to complete, very important. Now coming to intracardiac shunt. So intracardiac shunt responsible for hypoxemia is right to left shunt. So I am only discussing shunts responsible to hypoxemia. Now let us see what is normally happening. Normally from the body, majority of deoxygenated blood. So from the body, deoxy blood reaches the right heart. Okay. From the right heart, there is a big vessel called as pulmonary artery. So pulmonary artery takes the blood into lungs. In the lungs, there is gas exchange happening. So once gas exchange happens, from the lungs, there is another vessel called as pulmonary vein. So these pulmonary veins will open into left heart. Now from pulmonary veins contain oxygenated blood. So this oxygenated blood from the left heart through the aorta goes back into the body. So this is the basic circulation, students. So from the body, deoxygenated blood goes into the right heart into the lungs, lung into the left heart into the body. Nowhere there is no mixing of oxygenated and deoxygenated blood. So this side, everything, on the left side, everything is oxygenated blood, students. On the left side, everything is oxygenated blood. Whenever there is an abnormal opening like this, called as right to left shunt. So from the right side, this deoxygenated blood will make its way into the left heart. And from the left heart, it will go into the systemic circulation. So there will be mixed blood reaching the circulation. Now tell me, students, is mixed blood good blood or bad blood overall? It is bad blood. Because mixed blood is bad blood, it will not contain sufficient oxygen. So there will be hypoxemia. So what happens in right to left shunt? There is an abnormal opening. Because of this opening, deoxygenated blood will go into left heart and there will be mixing of blood. Mixed blood is always bad blood. So that results in hypoxemia. Now, this patient, because of hypoxemia, he will be coming to the emergency department. His SpO2 will be less. So what I will do, I will start giving him oxygen, supplemental oxygen, with help of nasal cannula or face mask. Now tell me students, after giving oxygen, will there be significant improvement in his SpO2? So will this patient be less responsive to supplemental oxygen or more responsive to supplemental oxygen? See, even if you give oxygen, so whatever oxygen you give extra will go into the lungs. So that oxygen will not have any effect on this shunt. Even if you give him oxygen, his SpO2 will not improve significantly. So this patient will be less responsive to, he will be less responsive to supplemental oxygen. He will be less responsive to supplemental oxygen. Then what is the solution? So how to improve oxygenation? So the ultimate solution is by doing a procedure that will close the shunt. So ultimate treatment is closure of shunt. So when you discuss various shunts in pediatrics and cardiology, so the treatment will be discussed in detail. But as a pulmonologist, I am more worried about intrapulmonary shunt. Now let us discuss about intrapulmonary shunt. Intrapulmonary shunt. So this is for you to understand the basics. So right to left shunt, so it will be less responsive to supplemental oxygen, because even if you give oxygen, there will be no influence on this movement of the blood. So best treatment is closure of the shunt by putting a device or doing some surgery. If you can close this defect, there will be no mixing and patient's saturation will improve. Now why this phenomena is called as a shunt? Now you can observe here patients, you can observe here students, there is movement of blood into circulation. So here there is movement of blood into circulation. And is this blood getting oxygenated? No. So there is movement of blood into circulation without oxygenation. And where it is happening? In the heart. So it was called as intracardiac shunt. So there is movement of blood. Follow this blue arrow marks. So there is movement of blood into circulation. And is this blood getting oxygenated? No. So the definition of shunt is satisfied. And where it has happened? Heart. So it was called intracardiac shunt. Now coming to intrapulmonary shunt, it was noticed in bad diseases, especially severe pneumonia, ARDS, and severe atelectasis. Atelectasis means alveolar collapse. Your alveoli are not opening. For all practical purposes, so we will take for understanding intrapulmonary shunt severe pneumonia as prototype. So before that, you should know what is normally happening in your body. So whatever I draw with this color, green, so it is normal phenomena happening in your body. Normally, you and me students will take oxygen. So this oxygen will reach majority of alveoli. And beneath every alveoli, there is deoxygenated blood flowing. So there will be deoxygenated blood. So this is deoxygenated blood. So this deoxygenated blood, once the oxygen comes into it, it becomes oxygenated blood. See, always in the beneath the alveoli, there can be some deoxygenated blood flowing. So once this oxygen reaches this blood, the end result will be oxygenated blood. So now blood becomes oxygenated. And the end result will be oxygenated blood. So this is something normally happening in all of us. So deoxygenated blood reaches the alveoli, and once the oxygen goes into the blood, it will become oxygenated blood, and oxygenated blood will come into circulation. Now let us see what happens when a patient is having severe pneumonia. So whatever I draw with this color, See, Utsav Anand. See, in cyanotic congenital heart diseases, so there will be pulmonary hypertension. So when there is pulmonary hypertension or pulmonary valve narrowing, so the pressure in the right heart increases. I think you are unaware of cyanotic congenital heart disease. Utsav Anand, do you know that there are some congenital cyanotic heart disease, tetralogy of Fallot? So in those conditions, there can be pulmonic stenosis. The pressure in the right heart increases. So when the right heart, and also there will be a opening. So because when the pressure in the right heart increases, the blood can flow into the left. So I thought you were aware of cyanotic congenital heart diseases, Utsav Anand. So such as tetralogy of Fallot. So where within the right heart the pressures can increase. So don't think all right to left shunt will cause this. So I am discussing shunts which ultimately result in hypoxemia. So right to left shunt, example tetralogy of Fallot. So if you go and discuss cyanotic congenital heart diseases, then it will become a cardiology class, Utsav Anand. So I have given you basic idea about intracardiac shunt. So you should be knowing that when will right to left shunt cause hypoxemia. So in the cyanotic congenital heart diseases such as tetralogy of Fallot. Okay. So in that condition, there will be increased pressure in the right heart. So that can result in movement of blood from right to left. So it is not a regular shunt. It is a shunt responsible for hypoxemia. I thought you were aware that we are discussing hypoxemia. So hypoxemia. So write down, whenever there is a disease such as pneumonia, severe pneumonia, now this alveoli will be filled with secretions like this. So it will be filled with secretions like this. Now this patient, let him also take oxygen. So this patient is also taking oxygen. So this oxygen, no doubt, will reach the blood. No doubt it will reach to this side. So this blood will turn to be oxygenated blood. So from this side, oxygenated blood will be coming into circulation. But what happens here? Oxygen cannot penetrate these secretions. Oxygen cannot penetrate these secretions. So this blood will not get oxygenated. So this blood will stay deoxygenated. Now this oxygenated blood and deoxygenated blood will now both come into circulation. So when both come into circulation, there will be mixed blood. There will be mixed blood. Now tell me, students, mixed blood, is it good blood or bad blood overall? It is bad blood. So patient will develop hypoxemia. Now tell me, why this phenomena is called as a shunt? Why this phenomena is called as a shunt? So see here, on the healthy side, you can see blood is getting oxygenated. Blood is getting oxygenated and it is going into circulation. On the unhealthy side, this part is not getting oxygenated. This part is not getting oxygenated, but still it is coming into circulation. Now if you observe here, there is movement of blood into circulation without oxygenation. Normally this blood should be oxygenated and come into circulation. But because this alveoli is completely filled with secretions, oxygen is not reaching this blood. So there is movement of blood into circulation without oxygenation. So this is called as shunt, and where it was happening? In the lung. So it was called as intrapulmonary shunt. So it was happening because of a lung disease. It was called as intrapulmonary shunt. So there is movement of blood into circulation without oxygenation. Because it is happening because of a pulmonary disease, it is called as intrapulmonary shunt. Now this fellow also has presented with hypoxemia. He might be in the emergency department and you have given him oxygen. Now after giving him oxygen, will he be more responsive to supplemental oxygen or less responsive to supplemental oxygen? Interestingly, this fellow will also be less responsive to supplemental oxygen. less responsive to supplemental oxygen. Now what is the reason behind this? Why is this patient less responsive to supplemental oxygen? Why is he less responsive to supplemental oxygen? Now say this O2, whatever I write with this color, is supplemental oxygen given through a face mask. Now whatever oxygen you give, definitely it will go into the healthy alveoli and it will reach this blood. So this blood becomes very well oxygenated. But this supplemental oxygen cannot penetrate these secretions. Because it cannot penetrate these secretions, this blood will be staying as deoxygenated blood only. So again, oxygenated blood coming into circulation, deoxygenated blood is also coming into circulation. So there will be persistence of mixed blood, and that will be responsible for hypoxemia. Now you should get a valid doubt. Sir, I am giving excess oxygen. It is going into one alveoli. So it is going into this blood. So what is the benefit of this excess oxygen? See here, one thing that you should know here is your hemoglobin is having a property called as saturation. So beyond a point, it cannot accommodate excess oxygen, students. See, even if you send excess oxygen to this side, your hemoglobin is having a property called as saturation. The maximum saturation is only 100%. It is not 200% or 300%. So this will be very well saturated. This is very well oxygenated. But this part always remains deoxygenated. So even the well oxygenated, if it mixes with deoxygenated, it will become mixed blood. So that results in hypoxemia. Now how to understand this concept? See, if a person's capacity is to eat one Hyderabadi biryani, even if you give 2 Hyderabadi biryani, his capacity is only 1 biryani. He will not take the second biryani. So on this side, this blood will be well oxygenated. So this is remaining deoxygenated. So when both mix, it will be a mixed blood resulting in hypoxemia. So this patient, even if you give oxygen, his saturation will not improve drastically from 75 to 95. So it will only improve minimally. From 75 it may improve to 78, 80, or it may not improve. So this patient will be less responsive to supplemental oxygen. Then what is the solution? So treatment for solution is, so no doubt, if there is an infection resulting in pneumonia, definitely you should give antibiotics. So for that antibiotics to function, and clearance of all that, it will take 48 to 72 hours. But till that time, how to manage the patient? Your answer should be invasive mechanical ventilation. Now what is the advantage of invasive mechanical ventilation? It is going to give oxygen with positive pressure. Now suppose there is a door in your room. Now 10 people are standing there. Now you want to go out through that door. Now how will you make yourself out through the door? You will push those people aside and you will rush in that space. In the same way, when you give positive pressure, that positive pressure can open the closed alveoli. So whenever alveoli are closed, see, whenever a balloon is closed like this, what is the best way to open it? Blow some air into it. So it will open the closed alveoli and facilitate gaseous exchange. If there are secretions, so it can expand the alveoli. It can push the secretions aside and facilitating oxygen entry into the circulation. So this invasive mechanical ventilation facilitates better transfer of gases. It facilitates better transfer of gases. You can see this was an alveoli filled with secretions, After giving invasive mechanical ventilation, that secretions can be pushed aside and the oxygen entry into the circulation can be facilitated. So point to remember, let it be an intracardiac shunt, students, or intrapulmonary shunt. Common thing, both will be ultimately less responsive to supplemental oxygen. So both can be less responsive to supplemental oxygen and treatment will be different for both. So let it be intracardiac shunt or intrapulmonary shunt, both will be less responsive to supplemental oxygen. Now tell me, students, what is this investigation in respiratory medicine which uses a gas called as carbon monoxide? Investigation in respiratory medicine which uses carbon monoxide. So it is called as DLCO, diffusion capacity of lung with a gas called as carbon monoxide. So why we were using this carbon monoxide? Because of its physiological property, has 200 to 240 times more affinity with which substance in your body? Hemoglobin. Then DLCO, the principle is, it is calculated as, this is the formula, DLCO is equal to difference between inhaled carbon monoxide minus exhaled carbon monoxide. So this is the principle. Principle is the difference between inhaled carbon monoxide and exhaled carbon monoxide. Now in this test what we are going to do is, so there will be a specialized mission like this. So patient is going to take inhalation. During inhalation I am going to send some DLCO. So this mission will calculate how much DLCO you have sent. And during exhalation again patient is going to exhale DLCO. And this mission will detect how much SIBO was exhaled. And by seeing the difference we are going to calculate DLCO. So don't go into panic thinking that SIBO is a very toxic gas. This might have some side effects. The amount of SIBO given is very minute quantities. It is equivalent to you traveling in your city's traffic for 10 minutes. In 10 minutes, how much carbon monoxide you are going to inhale? I'll be giving it in a span of 10 seconds. So write down DLCO. The principle is the difference between inhaled carbon monoxide minus exhaled carbon monoxide. To measure DLCO in the test, there are three phases. So one is deep inspiration, breath holding and forced expiration So we will see what will happen in the alveoli and the capillary. So generally in the capillary there will be blood. And what does blood contain? Hemoglobin. So these are the three phases. Deep inspiration, breath hold. So I ask the patient to take deep inspiration. I ask him to hold his breath and I ask him to exhale. So whenever patient takes deep inspiration, the mission is going to release carbon monoxide. Now for example, say 100 units of carbon monoxide. So this is only for just a simple example. Say 100 units of carbon monoxide has reached his alveoli. So during inspiration, the mission has sent 100 units of carbon monoxide into the lung. Now I am asking the patient to hold his breath. So whenever this patient holds his breath, 100 carbon monoxide units. So this carbon monoxide is concerned with only one substance in your body. What is that substance? Hemoglobin. Now tell me students, where is hemoglobin present? It is not in the alveoli, it is in the capillary. So to bind with that hemoglobin across any membrane, 10% is wastage. So majority of carbon monoxide will go into the capillary and it will bind with hemoglobin. Because carbon monoxide is only concerned with one substance. What is that substance? Hemoglobin. Where is hemoglobin present? Capillary. So this carbon monoxide will go into the capillary and bind with hemoglobin Now I am asking the patient to do forced expiration. Now think carefully and answer, students. So whenever patient does forced expiration, which carbon monoxide will come out? The one remaining free in the alveoli or the one bound with hemoglobin? The one bound with hemoglobin is never going to come out. The one free in alveoli will only come out, because carbon dioxide and hemoglobin are having a very strong affinity like this. See, once they bind with together, once they two bind together, once Kabir and Preeti bind together, it is very difficult to separate them. So the carbon monoxide bound to hemoglobin is never going to come out. Only the carbon monoxide remaining free in the alveoli will come out. Now let us see what will be the DLCO in a normal individual. See, whatever I have discussed up to now is a normal individual. In a normal individual, DLCO will be equivalent to how much is inhaled carbon monoxide? The mission has sent 100 units. How much is exhaled carbon monoxide? 10 units. 100 minus 10, it is 90. It means 90% of carbon monoxide, 90% of carbon monoxide has diffused into the circulation. It means the diffusion capacity is normal. So generally diffusion capacity will be 80 to 90%. By indirectly seeing the exhaled carbon monoxide, I am calculating the diffusion capacity. The rule here is, if the membrane is normal, majority of carbon monoxide will stay in the body. Less will come out as exhaled carbon monoxide. It means the DLCO is normal. So DLCO 100 minus 10, it means 90% of carbon monoxide has crossed the membrane. So patient's DLCO is normal. Now let us see what happens in a disease. So whatever I draw with this color is equivalent to a disease. Now say this patient's alveoli. So again I am removing all these values. Again I am conducting a fresh DLCO in a patient with disease in the alveoli. Say his alveoli is filled with so many secretions like this. Alveoli were filled with so many secretions like this. Okay, they were filled with so many secretions like this. Now in this patient also, he is going to inhale 100 units of carbon monoxide. Now during breath hold, now there is a barrier between these two people. So barrier between Kabir and Preeti. Now they cannot bind properly. Now through this alveolar secretions, because of this disease, your carbon monoxide cannot penetrate completely and go into circulation. Instead of 90 reaching the circulation, only 50 will reach the circulation. 50 will remain in the alveoli. So 50 in circulation, 50 in the alveoli. When I ask the patient to forcibly expire out, this alveolar carbon monoxide will come out. So this DLCO here, 100 minus 50, it will be 50. Here DLCO is significantly decreased. Say normal value will be somewhere 80 to 90%. It is 50. It means whenever there is a disease in your body, if it is not penetrating carbon monoxide to bind with hemoglobin, so majority of the carbon monoxide is not binding with hemoglobin, it will stay in the alveoli and it will come out as exhaled carbon monoxide. It means if exhaled carbon monoxide is increasing, see normally Kabir and Preeti should bind together and they should stay in a room called as body. They should bind together and they should be staying in the body. So if the binding is not proper, carbon monoxide will be coming out excessively from the body. If exhaled carbon monoxide is increasing, there is some problem in your body not allowing carbon monoxide and hemoglobin to bind together. So this is the concept that you should know. If there is increased exhaled carbon monoxide, there is some problem in your body. Not allowing carbon monoxide and hemoglobin to bind together. Now let us see what are the conditions where there is some problem between these two people. So decreased DLCO, and let us see what are the conditions where there is increased DLCO. To understand this better, again we are going to the basic relation of alveoli and capillary. Now let us see if there is some disease called as severe pneumonia, and there is disease called as ARDS. So in these conditions there will be excess secretions in the alveoli. This excess secretions cannot allow carbon monoxide to penetrate properly. Now between these two there are excess secretions. So it cannot penetrate, the carbon monoxide cannot penetrate and bind with hemoglobin. And third important disease, around your alveoli there is deposition of thick fibrous tissue. So around the alveoli there is deposition of thick fibrous tissue. And this fibrosis can also happen in ILD. See, ILD and fibrosis are similar phenomena. So in interstitial lung disease, the end result is fibrosis. Now between these two, there is a thick fibrotic barrier. So this girl's father has made a big gate between these two. Again, these two cannot bind properly. And next important reason, severe emphysema. So as we have discussed previously, whenever there is severe emphysema, there will be involvement of capillary walls, alveolar and capillary walls. So whenever alveolar and capillary walls are filled with inflammatory cells, see, normally the membrane should be like this, very sensitive and very smooth. Now if it is filled with inflammatory cells, dirty cells, now these dirty cells will not allow carbon monoxide to penetrate and bind with hemoglobin. So in severe emphysema, the alveolar capillary membrane is filled with dirty cells, and those dirty cells will not allow carbon monoxide to penetrate into the alveoli. So these are the conditions where carbon monoxide is present. It is ready to bind, but because of some situations around her, either there are secretions or there is fibrous tissue or inflammation involving the alveolar capillary membrane, as in severe emphysema, there is no proper binding with hemoglobin. Along with that, conditions such as anemia, pulmonary hypertension, pulmonary embolism, these are also responsible for decreased DLCO. Now can anybody tell me, why will anemia, why will pulmonary hypertension, why will pulmonary embolism be responsible for decreased DLCO? Very simple. Now see here students, for carbon monoxide to bind with hemoglobin, not only the membrane should be healthy, the amount of hemoglobin should be sufficient. See, for carbon monoxide to bind with hemoglobin, not only the membrane should be healthy, this hemoglobin should be interested. he should be in a good mood to bind with carbon monoxide. So whenever there is no sufficient hemoglobin, in anemia, there is decreased hemoglobin. Pulmonary hypertension generally happens due to pulmonary vascular narrowing. So whenever your pulmonary vessels are narrowed, blood will not flow properly. And whenever there is pulmonary embolism, blockage to pulmonary circulation, blood will not flow properly. Excellent Simran, excellent Dhananjay, excellent Razia, Mondal, everybody have answered very good. So either to decrease the hemoglobin or decrease the blood flow, there will be no proper blood available to bind. Now with this logic, what are the conditions responsible for increased DLCO? Very simple. Anemia was responsible for decreased DLCO, polycythemia. So polycythemia. The reason is increased HB. Then second, next cause is exercise. Can anybody tell me why will exercise be responsible for increased DLCO, increased blood flow? Now when somebody does exercise, across that alveoli, the blood flow increases. Previously across that alveoli, only 1 ml of blood was flowing. Now 2 ml of blood will flow. If more blood is flowing, more hemoglobin available. Because of more hemoglobin, there will be more exchange. See, I don't know why you are asking again this severe emphysema. So write down in severe emphysema. So whatever I have realized, there is involvement of alveolar capillary membrane by inflammation. So this Anshika, I have told you with example. Now there are two people Anshika here. In between them, there is a barrier called as inflammation. There is an inflammatory barrier. So there are inflammatory barrier. Because of that inflammatory barrier, the carbon monoxide is not binding with hemoglobin. Okay, inflammatory barrier. So they cannot diffuse properly. So the healthy membrane is very less. So involvement of alveolar capillary wall by inflammation. Okay. Then third important thing is alveolar hemorrhage. Alveolar hemorrhage. Now can anybody tell me why in alveolar hemorrhage there will be increased DLCO? Now what happens is in alveolar hemorrhage there is blood within the alveoli itself. So blood within the alveoli. So alveolar hemorrhage, there will be increased blood in the alveoli. There is increased blood within the alveoli. Now previously this carbon monoxide to bind with hemoglobin, it was going into capillary. Now where is hemoglobin present? It is present in the alveoli itself. Previously, these people to bind with each other, they were going to OR room. Now both are in their home itself. So what will happen? The binding will become more. Now this carbon monoxide is concerned with only one substance called as hemoglobin. So now hemoglobin is available in the alveoli itself. When both are present at a single place, they are present in a closed room. Will anything stop them from binding? Never. They bind more avidly. So CO binds with bleed. So that results in decreased exhaled carbon monoxide. So previously some amount of carbon monoxide was remaining in the alveoli, that was coming out. Now because carbon monoxide is binding with bleed, nothing will come out. Once you have closed the door, nobody is going to come out. So this carbon monoxide is not going to come out. So because exhaled carbon monoxide decreases, automatically DLCO will increase. So I hope you have understood the concept of alveolar hemorrhage, not the concept of home and OYO room, for God's sake, concept of alveolar hemorrhage. So in alveolar hemorrhage, there is bleed within the alveoli. This carbon monoxide will bind with hemoglobin of bleed and stay in the alveoli. It reduces exhaled carbon monoxide. Then last condition, not that frequently seen, not that frequently asked, but it can happen in asthma. Now what was the reason why it was happening in asthma? Because of in asthma, we know there is increased eosinophilic inflammation. In asthma. So whenever there is increased eosinophilic inflammation, there is a release of substance as a byproduct called as nitric oxide. Whenever eosinophilic inflammation happens, there is a substance called as nitric oxide released, and this nitric oxide can result in pulmonary vasodilatation. So this explanation of DLCO is dedicated to all OYO couples. Okay, don't worry. So asthma, there is increased eosinophilic inflammation. Because of increased eosinophilic inflammation, the byproduct is nitric oxide, students. So byproduct of nitric oxide has a property called as pulmonary vasodilatation. Now because of this, the blood will flow more and there will be increased DLCO. And recently, because asthmatics were having more nitric oxide in their lung, there is a new test called as FeNO. So FeNO means fraction of exhaled nitric oxide. Just write down, I'll tell you what is this. Fraction of exhaled nitric oxide. So this fraction of exhaled nitric oxide is actually one of the new tests for asthma. So FeNO. So FeNO is fraction of exhaled nitric oxide. So we have found that asthmatic lungs was containing more nitric oxide. Now these Americans have designed a mission called as FeNO. So what will that FeNO do? When an asthmatic blows out into that mission, because asthmatic lungs are containing more nitric oxide, that mission will say his exhaled breath is having more nitric oxide. So very simple, students. If you consider this is an asthmatic lung. So asthmatic lung is containing more nitric oxide. So when he exhales, even his exhaled breath will be containing more nitric oxide. And there is a mission called as FeNO, which will detect the exhaled nitric oxide. And compared to normal individual, asthmatic's lung contain more nitric oxide. So whenever asthmatic blows into that mission will detect more nitric oxide in his exhaled breath. So this mission is called as FeNO. So FeNO is fraction of exhaled nitric oxide. It is a test for asthma. So students, this is very, very important. What are the conditions responsible for decreased DLCO? What are the conditions responsible for increased DLCO? So this table will be sufficient to answer any question regarding DLCO. Conditions increasing DLCO, decreasing DLCO. So this is the mission for your identification. So asthmatic lung is containing more nitric oxide, and this nitric oxide can be detected by a special mission called as FeNO. So whenever nitric oxide is more, it means there can be eosinophilic inflammation, and most important eosinophilic inflammation happening in the lungs is asthma. Now what is this test? Patient is taking deep inspiration followed by forced expiration. You are having a flow volume curve. So this is called as spirometry, students. So write down basic pulmonary volumes and capacities. Again, Spirometry will be discussed in detail in your physiology, but just for your convenience to understand what is obstructive and restrictive, you need some basic concepts. So we will have a quick review of basic pulmonary volumes and capacities. So this is the fundamental diagram. Just answer the questions. You know everything, whatever I discuss in this slide. Whatever you don't know, that only you write down. Now tell me, students, observe me. I am taking normal inspiration and I am doing normal exhalation. Whatever somebody normally inhales or normally exhales. So normal inhalation, normal exhalation. What is volume number 1 called as, students? I want you to answer quickly. What is volume number 1 called as? It is called as tidal volume. So tidal volume is volume of air inhaled or exhaled normally during each respiratory cycle. Volume of air inhaled or exhaled normally during each respiratory cycle. Now see here, after taking normal inhalation, I have put some extra effort. If I put some extra effort, my lung is accommodating extra amount of air. So this extra accommodated after normal inhalation, it is called as inspiratory reserve volume. Now tell me, students, now I have taken normal inhalation. After that, some extra effort. What is number 2? What is number 2? Yes, number 2 is inspiratory reserve volume. So inspiratory reserve volume is maximal volume of air inhaled with effort after tidal inspiration. Inspiratory reserve volume is maximum volume of air inhaled with effort after tidal inspiration. Okay, now see here. Again, I am throwing everything out. See, again, normal inhalation, normal exhalation. Even after normal exhalation, students, if I put some extra effort, my lung is expelling some extra amount of air. What is number 3? Extra expelled out after tidal expiration. It is expiratory reserve volume. Maximum volume of air exhaled with effort after tidal expiration. So maximal volume of air exhaled with effort after tidal expiration. So this is ERV. Now I am taking deep maximal inhalation. Forced expiration. Even after forced expiration, always some air remains in my lung. It is called as residual volume. What is number 4? That remains even after forced expiration, residual volume. Volume of air remaining in lungs after maximal exhalation. Volume of air remaining in lungs after maximal exhalation. Now very simple. Observe here. You can do it with your hands. Very simple. Normally in or normally out is tidal volume. After normally in with some extra effort, inspiratory reserve volume. Again, after normally out with some extra effort out is expiratory reserve volume. Deep maximal inhalation followed by forced expiration. Still something remains in your lung. That is called as residual volume. That is called as residual volume. Point to remember, volumes are individual parameters. Combination of volumes is called as capacities. All lung volumes, if you total all lung volumes, it is called as a capacity called as total lung capacity. Very simple. Sum of volumes is called as capacity. All lung volumes put together, it is called as total lung capacity. All lung volumes put together, it is called as total lung capacity, students. It is called as total lung capacity. Now let us name it easily. So first two lung volumes put together, it is also called as a capacity. First two lung volumes put together is called as a capacity, because any combination of volume should be called as a capacity. So this capacity is called as inspiratory capacity. First two lung volumes put together it is called as a capacity. This capacity is called as inspiratory capacity. Last two lung volumes is also called as a capacity. See, I have named first two volumes. So if I don't name last two volumes, it will be incomplete. Last two volumes is also called as a capacity. It is FRC, functional residual capacity. So FRC means functional residual capacity. I'll write it separately. FRC means functional residual capacity. Functional residual capacity. So for all put together, in total lung capacity. First two inspiratory capacity, last two functional residual capacity. Now tell me, what is this, students? I am taking deep maximal inspiration followed by forced expiration. So whenever I exhale, the exhaled breath will be containing tidal volume, inspiratory reserve volume, expiratory reserve volume, except residual volume. So this parameter containing all this except residual volume, it is called as forced vital capacity. So this parameter is called as forced vital capacity. So frequently asked, forced vital capacity contains all lung volumes except residual volume. Another question, the difference between total lung capacity and forced vital capacity is again residual volume. So two questions. Forced vital capacity contains all lung volumes except residual volume. The difference between total lung capacity and forced vital capacity is again residual volume. Now let us represent the important volumes and capacities with help of a water tank model. So clinically relevant volumes and capacities. Consider this is a water tank, this is a water tank, and whatever this water tank can completely accommodate, this is called as total lung capacity. So whatever the water tank can completely accommodate is total lung capacity. Now let this water tank have a tap like this. So whenever I turn on this tap, whatever comes out eventually, it is FVC, forced vital capacity. Even after turning on the tap, some amount of water will never come out. This is called as residual volume. See, consider your lung equivalent to a water tank with a tap. So whatever your lung can completely accommodate, or whatever this water tank can completely accommodate, is total lung capacity. When you turn on the tap, whatever comes out eventually is FVC. That which never comes out is residual volume. Let us see the definitions. Total lung capacity. Volume of air accommodated at deep maximal, volume of air accommodated at deep maximal inhalation is total lung capacity. Then we have FVC, air expelled forcibly after deep maximal inhalation. Air expelled forcibly after deep maximal inhalation. If you see here, students, these two will be in a sequence. Observe me. I am taking deep maximal inhalation. I am taking deep maximal inhalation. What is my lung containing now? It is total lung capacity. Now I am doing forced expiration. When I do forced expiration, what is coming out? It is forced vital capacity. What still remains? Residual volume. Very simple. See, now I have taken deep maximal inhalation. When I have taken deep maximal inhalation, what is my lung containing, students? Total lung capacity. Now when I do forced expiration, What did I expel? Forced vital capacity. And what is still remaining? Residual volume. Apart from this, very important for clinical purpose is timed vital capacity. So timed vital capacity. And in that, most important parameter is FEV1. FEV1. Now what is this? Now suppose there is 100 units of air in your lung which has to be expelled forcibly in 3 seconds. So why I am taking 3 seconds? Because normal expiratory time is 3 seconds. So whenever a patient forcibly expels out, this 100 units will not come out as 33 units in first second, 33 units in second, 33 units in third second. So why it will not come out like that? Because whenever somebody does forced expirator, maximum recoil will be during the first second. So majority of air will be coming out during the first second. Rest will be coming out during the next 2 seconds. So FEV1 is FVC at end of first second. It will be usually 70 to 80%. It means, students, whenever a patient is expelling out 100 units of air, eventually at the end of first second, normally how much should come out? 70 to 80% should come out at the end of first second. So with this background, there is a ratio developed. So this ratio is called as FEV1 by FVC ratio. It means if a person is expelling out 100 units of air eventually, how much should come out at the end of first second? 70 to 80. So the ratio is 70 to 80%, or in terms of decimals, it is written as 0.7 to 0.8. Very, very important ratio for clinical purposes. FEV1 by FVC ratio. If a person is expelling out some quantity of air eventually, how much should come out at the end of first second? Specifically 70 to 80%. 70 to 80%. See, FVC is maximal exhalation. Sorry, I have after deep maximal. No. It is the same. You have confused. See, I don't know, Fatima. See, air expelled forcibly after deep maximal inhalation. See, you have to inhale, then only you will exhale. So, Fatima, see here, what is FVC? So, for you do one small favor for me. So, how will you exhale? Only if you inhale. How will you forcibly exhale? If you take maximal inhalation. Just Fatima, do this simple favor for me. Take deep inhalation. And now you do forcible expiration. So whatever has come out is FVC. So what did you do? You have done forcible expiration after deep maximal inhalation. So that is common sense. So air expelled forcibly after deep maximal inhalation. So you are expelling forcibly after taking deep maximal inhalation. That is FVC. That is the definition of FVC. Now next important is what is PEFR and what is MEFR. So what is PEFR, what is MEFR? Now again, basic physics, nothing complicated. Now suppose you are having a ball in your hand, students. Now you are throwing it to some distance. So initially this ball will reach an highest velocity. After reaching that highest velocity, will it immediately fall down or will it travel to some more distance and fall down? So it will travel to some more distance and fall down because of influence of gravity and inertia. In the same way, whenever somebody is taking deep maximal inhalation and doing forcible expiration, this exhaled breath initially will reach an highest velocity. So that highest velocity is called as PEFR. Later, the mission can calculate an average velocity. So that average velocity calculated by the mission during the mid portion of expiration, it is called as MEFR. So write down PEFR is peak velocity during FEC. PEFR is peak velocity during FEC. MEFR is average velocity calculated during mid portion of expiration. Now this PEFR signifies flow in large airways. Flow in large airways. Then MEFR signifies flow in smaller airways. So MEFR signifies flow in smaller airways. MEFR signifies flow in smaller airways. Now what is the logic behind this? See, very simple. Whenever I blow out forcibly, air from the large airways will come out first. So this flow coincides with PEFR. Then air from the tiny airways will come out next. This coincides with MEFR. See, whenever I say air from the proximal airways come out first, so which are large airways? So later air from the distal airways come out first. Few students will be always confused. So for them I'll give them a simple example. So now suppose you are having something in your mouth. Now you have developed vomiting. Now tell me students, what will come out first? Will the gastric juice which is very distal will come out first, or the chocolate in your mouth which is very proximal will come out first during vomiting? So whatever is in your mouth will come out first, then the gastric juice will come out next. In the same way, when somebody does forcible expiration, air from the proximal airways will come out first, then only air from the distal airways will come out next. So this proximal airways are generally large airways. So your trachea, bronchi, all those segmental bronchus. So this flow coincides with PEFR. And whereas flow from smaller airways which comes next can coincide with MEFR. Now how is this clinically helpful for me? Now there is a disease called as asthma. There is another disease called as COPD, emphysema specifically. So which parameter will be helpful in asthma? Which parameter will be helpful in emphysema? By common sense you should answer this, students. Which will be helpful in emphysema? Which will be helpful in which will be helpful in asthma? See, where is asthma happening? Bronchi. What are bronchi? Bronchi are considered as medium to large sized airways. That's why it is called as bronchial asthma. So PEFR is useful for monitoring of bronchial asthma. So PEFR is generally useful for monitoring of bronchial asthma. In the same way, where is emphysema happening? Emphysema is happening in distal to terminal bronchiole, where you have tiny airways. So this MEFR useful in monitoring of emphysema. So whenever I say PEFR monitoring, which disease should come into your mind? Asthma. Whenever I say MEFR, which disease should come into your mind? Yes, tell me students, COPD, emphysema. Now all these volumes and capacities, they can be measured. How are they routinely measured? They are measured by a device called as spirometer. Now this spirometer will be having a sensor. Whatever volume or flow hits that sensor, it will detect as respective flow or volume. So a conventional spirometer, conventional spirometer can measure all lung volumes except what should be your answer? Conventional spirometer can measure all lung volumes except residual volume, because residual volume will never come out and hit that sensor. So write down, conventional spirometer cannot measure residual volume. So if cannot measure residual volume, can it measure FRC? No, because residual volume is a component. Can it measure TLC? No, because here also the for TLC residual volume is a component. TLC residual volume is a component. So these three parameters cannot be measured by conventional spirometer. Then how are they measured? They are measured by special methods such as, just know the names of the methods. Helium dilution method, that is sufficient. Helium dilution method. Nitrogen washout method. Nitrogen washout method. And the famous advanced body plethysmography. Body plethysmography. So this body plethysmography, B for body, B for best. This is the best method to measure lung volumes overall. If they ask you out of all this, which is best method, your answer should be body plethysmography. Body plethysmography is considered as the best method. These are volumes and capacities happening normally in all of us. Now let us see how to classify respiratory diseases based on spirometry into obstructive and restrictive. Before that, you should know some rules of spirometry. Rule number 1. All the spirometry values generally compared with normal values of that given age. So whenever I say patient's FVC is 60% of predicted, it is normal value, it is 60% of normal value of that given age. Whenever I say patient's FVC is 40% of predicted. So 40% of predicted. So 40% of predicted, it means 40% of normal value of that given age. So Namita, emphysema, MEFR, because emphysema happens in small airways. Small airways. So definition of emphysema, destruction distal to terminal bronchiole. See, I think I should write every alphabet for you. PEFR, asthma. So if I miss, somebody will ask me the question. So for COPD emphysema, MEFR is preferred. So that's why in a spirometry report, you will be having patient's observed value, predicted value and percent predicted. So always spirometry values compared with normal values of that given age. Normal values of that given age. First rule. Second rule. A normal person can expel out in 3 seconds. But if required, a spirometer will wait up to 6 seconds. So why it will wait up to 6 seconds? So to see whether this fellow has overcome the obstruction and expel the extra amount of air. So rule number 2, a normal person can expel out in 3 seconds. But if required, a spirometer will wait up to 6 seconds to see whether this fellow has overcome obstruction and expelled extra amount of air. Again, for your basic information, whatever you empty out eventually is FVC. In that, what comes out at the end of first second is FEV1. See, whenever you are emptying out your lung, the amount specifically coming out at the end of first second is FEV1. What comes out eventually is FVC. Now let us see the comparison of obstructive, restrictive with respect to normal individual. So normal individual, again the same water tank. So very simple. Let this be the total lung capacity. And whenever you turn on this tap, whatever comes out eventually, it is FVC. That which never comes out, residual volume. And whatever comes out at the end of first second is FEV1. See, FVC is the amount coming out eventually. FEV1 In that, what comes out at the end of first second? Because it is a normal individual, FeV1 will be normal. Because normal, we take everything as normal. So FeV1 by FeC. Because both are normal, the ratio will also be normal. So let us see with a numerical example. Consider patient's FeC as 5 liters. In a normal individual, if it is 5 liters, FeV1 will be 4 liters. So the ratio 4 by 5 into 100. So the ratio 80%. Normal is 70 to 80%. Nothing to worry. So this is a normal individual's lung. FeV1 will be normal, FeC normal, ratio will be normal. So nothing new here, everything is normal. So normal FeV1 by FeC. Now suppose you are doing it in an obstructive lung disease. Now how is obstructive lung disease different? Let us see in detail. This will be total lung capacity. When you turn on the tap, whatever comes out at the end of first second, FeV1. What comes out eventually, FeC. That which never comes out, residual volume. The main difference is, in this tap, there is an obstruction. Narrowing in the airway, students. Narrowing in the airway. So there is narrowing in the airway. Now tell me, students, whenever there is narrowing in the tap, when compared to normal tap, the amount of FeV1 here, will it be normal or decreased? It will be significantly decreased. So when compared to the normal tap, the amount of water coming out at the end of first second is significantly decreased. Then what happens to FeC? FeC can be normal or only slightly decreased. Now you can get a valid doubt why here FeC is normal or only slightly decreased. See here, very simple logic. Now consider this is a normal individual's lung. So whenever I open the tap, okay, whenever I open the cap, now what is happening? Whatever comes out at the end of first second is FeV1. Whatever comes out eventually is FeC. Now if there is an obstruction like this, see at the end of first second, the amount coming out will be definitely less. It will be definitely less. But if you give this bottle sufficient time, it may not empty out at 3 seconds like a normal individual. But if you give it extra time, it may empty out at 6 seconds. See, FeC is nothing but amount coming out eventually. It is not at the end of 3 seconds, 4 seconds. But FeV1 is the amount coming out specifically at the end of first second. So when this bottle is obstructed, specifically at the end of first second, it will be less. But eventually this bottle can empty out by giving extra time. Same thing spirometer will do. If required, it will provide extra time for expiration. It will wait up to 6 seconds. So in this situation, because FeV1 is predominantly reduced, FeC can be normal. FeC can be normal. Numerator is decreased. Always the ratio will be decreased. Because numerator is decreased, the ratio will be decreased. Simple mathematics. When numerator decreases, ratio will always be decreased. Now coming to restrictive lung. Now what is meant by restrictive lung? Restriction means something which is not expanding. So whenever something is not expanding, whenever your lung is not expanding, so what will be the total volume of that lung? It will be significantly less. So if you consider this is normal lung, this is normal lung. So this will be restrictive lung, a small lung, a small lung. So it will be a small water tank, students. It will be a small water tank. And to this will be its total lung capacity, FeC. At the end of first second, FeV1. And this will be the residual volume. So when compared to normal individual, the amount coming out at the end of first second will be significantly reduced. The amount coming out at the end of first second will be reduced. FVC FVC when compared to normal individual will be reduced. So if both are symmetrically reduced, FEV1 reduced, FVC both are proportionately reduced, the ratio can stay normal. Now if you do this with a mathematical example, you will understand. Now a normal individual's FVC is 5 liters. This fellow's FVC can only be 2.5 liters. A normal individual can expel out 4 liters. This fellow can only expel 2 liters. Now if you see the ratio, 2 by 2.5 into 100. So 40 times. So it is 80%. So the ratio has remained normal. But there is an exception. So in few cases, there can be disproportionate decline. There can be asymmetric or disproportionate decline in FEV1 and FVC. So what happens is in few individuals, so whenever there is some irregular fibrosis, okay, FEV1 will be declined. When compared to FEV1, the proportion decline in FVC will be higher because denominator, the decline is higher. The ratio can be increased because denominator is declining. The ratio can be increased. Now for this also I will give you proper example. So in few situations the values can be like this. This FVC can be decreased to 2 liters. FEV1 can be decreased to 1.7 liters. Now if you see the ratio 1.7 by 2 into 100 to 50 so 1.7 into 50, it will be 85%. See, normal is 70 to 80, it is 85%. So the ratio has increased. So simple logic, in a normal individual, everything tends to be normal. In an obstructive lung disease, because numerator is predominantly decreased, the ratio will always be decreased. In a restrictive lung disease, the overall capacity of the lung is decreased. So the capacity to expel has significantly decreased. It is significant decline in FVC because denominator is the one significantly declining. So the ratio can stay normal. The ratio can stay normal or increase. The ratio can stay normal or increased. Okay students, now keep this important concept in your mind. So in obstructive lung disease, just close your eyes. In obstructive lung disease, numerator is predominantly declined, so the ratio will be decreased. In restrictive lung disease, it is the denominator. The capacity to expel might be significantly declined. So it is the ultimately the lung capacity is involved. So FVC is declined. So the ratio can be normal to increase. Ratio can be normal to increase. So we will conclude for today. Tomorrow we'll start with the spirometry algorithm. So till then I want you to know this. So this is a normal individual, everything will be normal. Obstructive, the ratio will be declined. Restrictive, the ratio can be normal to increase. So any doubts up to now? I'll be here for another few minutes. You can ask me. Good night students. So thank you so much for your appreciation, students. I'm also very happy interacting with you. So whenever I speak in don't think I'm sometimes sarcastic. So I'm sarcastic so as not to criticize or humiliate you, to make you more interested and to create interest in you. So don't think in other way, so that I'm being sarcastic to either insult or humiliate you. So it is not my view. It is only to encourage you and make you to understand. See, sometimes when you make a mistake, if we don't correct it, so it will be a bigger mistake made by your teacher. So even for my postgraduates and my interns, whenever they make some mistake, I'll definitely correct them. Not in very harsh manner, not in very smooth manner. It will be something in between. So pulmonary hypertension point in pulmonary hypertension, Zaid, it usually happens due to pulmonary vascular narrowing. So pulmonary hypertension, it happens due to vascular narrowing. So whenever your vessel is narrowed, Zaid, the amount of blood flowing will be less. So the reason is this: pulmonary hypertension. See, normally your your vessel will be like this. In pulmonary hypertension, blood may not flow properly. So Jawahar Prem K, in stable patients, see, patient is stable. So patient is stable, still clot has not blocked. See, what you should do is, Jawahar, in medicine, only when a complication happens, you should use the last resort. See, if clot, see, why we are doing rigid bronchoscopy? To remove that clot. See, it will only be done when the clot blocks. So it is just like, suppose you are having suppose somebody is having an accident, so he might get a head injury. So because he might get a head injury, you will not put a burr hole immediately before going into an accident. So if accident happens, you have to treat. See, there is massive hemoptysis. So still the clot is not blocking his trachea. If clot is not blocking his trachea, no point in doing suction. So why the ventilation and perfusion defect? Again, it is simple English. It has been, so Kanimozi and Survo. See here, there is defect both in ventilation and perfusion, and it was found to be asymmetric. When they did calculations, it was found to be asymmetric. It was not the same. So Shivani, you need spirometer part. Which part? Which part? See, there was defect both in ventilation and perfusion, and when they have made mathematical calculations, it was asymmetric. So both were asymmetric. That's why there was ventilation perfusion mismatch. So the ventilation defect is airway narrowing, perfusion defect is involvement of capillaries. So Shivani R, you need which part of spirometer? Spirometry. Don't say everything, sir. It will take another half an hour. So tomorrow we'll meet by 2 o'clock and we'll try to complete the class by 9:30. 9:45. So conventional spirometer cannot measure. See, that spirometer will be having a sensor. So whatever comes out from your lung, it will hit that sensor and it will detect. Because residual volume is never coming out from your lung, that sensor cannot identify residual volume. See, how will you, simple example Shivani, how will you know about a person who is never coming out from the hostel room? Suppose there are 3 of your roommates. You are tidal volume, your friend is inspirated reserve volume, another fellow is expirated reserve volume, and there is some person who is never coming out from your room at all. So if you ask your another person who is staying in the next room, he will only explain about you 3 people. He will never explain about 4th one, because 4th one is never coming out from the room. In the same way, for a spirometer to measure, it should come out from your lung and it should hit that sensor. Residual volume is never coming out. Because residual volume is never coming out, it cannot be measured. Total lung capacity, residual volume is a component. FRC, residual volume is a component. See, PEFR, how is it calculated? So there is a mission, you blow into the, see, Dhananjay, so PEFR, MEFR, everything can be measured by conventional spirometer. Everything will be measured by conventional spirometer except residual volume. Because PEFR also you are blowing out. Okay then. So I'll take leave for today.